So we are going to start the first session of today. We welcome you all to Ophthalmologica Online 2025. So first speaker for today is Dr. Agnieszka Nowosielska, and we invite her for a presentation on submacular hemorrhage surgery tips and tricks. Madam is a leading ophthalmologist and VR surgeon and the founder of Warsaw Eye Hospital in Poland. She boasts several international internships at renowned clinics in Hamburg, Wills Eye Hospital, Moorfields Eye Hospital, where she also completed her training for VR surgery. And she has authored numerous scientific papers, presentations, and co-authored the Polish translation of two books, Wills Eye Manual and Basic and Clinical Science Course, Volume 15. We welcome you, Madam, for your presentation. On to you. Thank you.
Is it sound okay?
Yes,
Hello?
Madam. We can see your presentation and we can hear you too.
Okay, great. So my topic for today is the management of subretinal hemorrhage, submacular hemorrhage actually, with TPA. And we all know that this is quite a devastating phenomenon. And if such occur, usually the visual acuity in the eye is affected. And if nothing is done, the visual acuity is very, very poor. We know that blood destroys the vision in the eye in numerous ways. First of all, is a toxic effect and a mechanical effect on the photoreceptor when the fibrin gets together and gets sticky to the photoreceptor endings. Our friends from neurology and cardiology many, many years ago discovered the influence of TPA, which is tissue plasminogen activator, which dissolves the clot and actually it helps to bring back the circulation. So what was used for several years right now is TPA to treat the submacular hemorrhages. How can it be put into the eye? The first concept of using TPA was to put the TPA into the vitreous cavity in a higher concentration with the hope that TPA will go to the posterior pole, resolve the clot, and then the clot will disappear from the affected area. Some of the authors combine TPA given into the vitreous cavity with vitrectomy, and then they put the gas bubble to the eye and in a hope that it will remove the clot from the affected area. In my opinion, the very successful way to use TPA in a submacular hemorrhage is to put the TPA right where the clot is situated, where is into the posterior pole. Here you can see my first ever made case. I do retinotomy with a cutter because I didn't have a special cannula to put TPA under the retina. The blood doesn't want to go from under the retina, as you can see, because the fluid needle doesn't work. And at that time, I didn't have a special cannula, so I used cataract cannula to give TPA. And I also managed to give some air under the retina, but it was actually unintentional. The result of this surgery was very, very good. As you can see, the visual acuity is marvelous, but this is my only and just one case where I did such a spectacular outcome. Never ever I repeated that success. But this gave me the idea that giving the TPA and removing the blood from under the retina is a way to go. At the moment, presently, what I use is 40 gauge cannula, which is specially designed to give the TPA under the retina. Here you can see that I administered from both sides the special solution. It was done because of the state of the macula, because it is fibrously changed due to the AMD changes, actually. I also strongly believe that if we dissolve the clot, as you can see on these pictures, we don't need to use air bubble or gas bubble that much. The TPA works in such a way it dissolves the clot, which is fibrin, into the liquid form. So if we put the patient into the upright position, gravity does the work. and we don't need to use any gas bubbles. We don't need to displace the hemorrhage, because the hemorrhage goes down by the gravity and goes down by itself. When we perform vitrectomy, we also can address all the other issues that are present in the eye, which is a subretinal hemorrhage, epiretinal membrane, and actually as you can see here, macular hole. And all of those is possible when we use surgical techniques. My technique at the moment, as I said, is using the special 40 gauge needle. I use very low concentration TPA, which is 12.5. I don't use air under the retina. I don't use anti-VEGF under the retina, because I tend to minimize the amount of the fluid that is given under the retina. I would like to share my experience about the population of the patient I operated. I had 48 patients, and I performed the same technique. And these are my results. 48 patients were operated on, and the mean time before when the hemorrhage occurred and when the surgery was performed was very long. And because I made the idea that I need to operate all of those patients, doesn't matter when they come to the clinic. I measured all the parameters of the patients. I measured the area of the hemorrhage, the thickness of the hemorrhage, the location. And what I found actually was that the success of the surgery did not rely on the location of the hemorrhage, because the successful operation was when the hemorrhage was under the retina, under the RPE and the retina. There was no correlation between the area of the hemorrhage and the success rate of the retina. And as you can see, the borderline of the successful surgery was 30 days after occurrence of the hemorrhage. That meant that when the surgery was performed up to 30 days when the hemorrhage was present, the visual acuity was quite good. And just after 30 days after the occurrence of the hemorrhage, you could see the slight decline in the visual acuity. This slide actually says it all, because it gives you the idea of the improvement of the visual acuity. And if we want to give the visual acuity by Snellen charges, we can say that patient improved from hand movement to 0.1, 0.2, which is the average of the visual acuity that I experienced. The most dangerous complication of this technique is formation of macular hole, actually, and that is why I don't give any additional volume under the retina. Here you can see the video from the surgery where actually such a complication occurs. You can see that small bubbles of air comes from underneath the retina, and these are and you can see that the macular hole was formed. Fortunately, this macular holes can be easily operated on using classical technique with peeling and gas tamponade, and they can be easily omitted when we use advanced technique, which is the administration of TPA using special devices. I use EVA operating system, and I don't have any financial interest in saying about this equipment, but recently I started using this special administrating system. The TPA is given automatically by the machine, and the administration is much more controlled, because it's slow, it's in a steady mode, And given under the retina, you don't give too much volume in a short period of time. That is why everything is much more controlled. You can see how it is done. From the technical point of view, this is exactly the same as you can administer the TPA from the hand, let's say. But this is done with a machine, with a foot switch as a control port. So it is much more reliable. Putting this all together, even if performed late after the onset of the hemorrhage, the TPA given under the retina improves the vision of the patients. But we need to take under consideration that there is another disease in the eye, which is wet AMD, and success of the surgery depends also on the state of the macula when the surgery was performed. Thank you very much for your attention.
Thank you so much, ma'am, for the wonderful presentation and your surgical insights. I just have two simple questions. One is that, do you have any recommendations based on the size of the lesion? I mean, how big the hemorrhage is, whether it's arcade to arcade, within the arcade, beyond the arcade, any recommendation?
Because they are we need to assess the range of the size. First of all, I think that anything bigger than 1 disc diameter, situated exactly in the center of the macula, is worth the surgical approach. This technique is suitable for hemorrhages, I think, up to the arcades and maybe a little bit above the arcades. Anything bigger, I think we need to go under the retina. Usually you need to do retinotomy and wash the blood from the side, elevating the retina up. There is a technique with RPE transplantation as well, and this technique is very good when the RPE is compromised and we have very, very destroyed macula. What maybe I did not emphasize enough here is that the success of this technique with TPA only lies on the state of the macula, of the retina in the macula, because when the retina is very much compromised, removing of the blood will not improve the vision much. So fresh cases, let's say not very advanced AMD patients, which happens to have hemorrhages.
Okay. Because we tend to use this procedure for larger hemorrhages.
Okay.
For smaller ones, we generally tend to use the office-based procedure, that is pneumatic displacement with maybe an anti-VEGF. So have you found again any difference again when it comes to smaller lesions? I mean, doing a vitrectomy with subretinal TPA?
I tried displacement, but I was not that skillful as you are in pneumatic displacement. And I found that giving the drug exactly in the place when it's needed in a controlled manner is better. Given the TPA to the bigger hemorrhages than to the arcades, sometimes I ended up with lots of remnants in the vitreous, and it took a long time for the vitreous to clean up after such a surgery. So it might be tricky for some time. So if somebody would like to actually start this technique, I would recommend maybe some hemorrhages in the middle range, not too small, not too big for the start. But as you know, that each surgery in those cases is different because each eye is different, and we need to take under consideration that those patients have two problems. They have hemorrhage and they have destroyed macula due to wet AMD. So everything depends on combination of those two.
Okay, thank you so much, madam.
Answer
Thank
your
you.
question. Thank you.
May I ask a question also?
Yeah, sure.
Yeah. I'm wondering, do you routinely perform vitrectomy and subretinal TPA, or what do you think about performing intravitreal TPA? There recently success rates reaching 90% have been reported using intravitreal TPA and gas injection for submacular hemorrhage, especially for those who are not good candidates for surgery with intense systemic diseases, dementia, and other things. What do you think?
Of course, I mean, whatever you are good at, you should perform. If you are better with pneumatic displacement, I don't see any reason why this procedure should not be performed. As I said, I tried pneumatic displacement many years ago, and I was not successful. Maybe my technique was not very perfect. Maybe I did something wrong. I don't know. But unfortunately, I started doing vitrectomy, and actually, it's so simple. It takes 20 minutes, and it is done in local anesthesia. And I pretty much don't see any reason. I didn't have any patients whom were so sick that was not possible to perform 20 minutes vitrectomy in a local anesthesia. I don't know. Recently, I was involved in Tiger study, and in Tiger study, as you know, there is a study to perform vitrectomy versus anti-VEGF only treatment. And I'm very happy to be in this study, and I'm very curious about the results, because I think that only big number of cases will answer those questions. The problem with subretinal hemorrhages is that lots of people does different technique, and they have very small numbers of patients. And those techniques are very difficult to be put into one basket, because each of them of surgeons, they perform things in a different way. So it's very
Yeah.
difficult to compare the results. That's why I kept on doing my technique, the one and the same all the time, to be able to collect any data and any conclusions. Because if you change your technique from time to time, you cannot make any conclusions, because you have too many variables.
Yeah, yeah, I agree. Thank you.
No, you're welcome. Thank you so much.
So we may go on to the second talk, I guess. Our second speaker is Dr. Ahmet Habib. He's currently serves as a senior vitreoretinal surgeon and associate professor in ophthalmology at Ain Shams University, Cairo, Egypt. And he's the co-founder of Al Mashrak Eye Center, which is specialized in VR surgeries. And also he is the head of ROP surgical retina and screening team at the same center. He has an extensive surgical experience, including more than 6,000 vitreoretinal surgeries. And the topic of his presentation will be intraoperative fluorescein angiography, what I've learned. Please feel free to go ahead, Dr. Habib. We are listening.
So hello everyone. I need to share the presentation. Okay. I need the host to allow me to share the presentation, please. Dr. Swati? The host is not allowing me to share the presentation.
Dr. Habib, you can start. We're waiting for the
It's
host.
not allowing me to share the presentation, V.
Just one second. I'm just asking.
Hello.
Yes.
Yeah. Click on
Please.
share button. Then double click on first option, that is screen or desktop.
I pressed on share.
Yeah. Click on share button at the bottom side
Yes.
and then double click on first option, that is desktop or screen.
There's no options given to me. It's saying sharing is not turned on. The host isn't allowing sharing for the meeting.
I allowed, wait. Yeah, now do once again. I allowed you.
That's okay.
Yeah, thank you.
That's okay. Thank you. So is it on?
Yeah, we can hear you.
Okay. So the intraoperative fluorescein angiography has been there for a long time. Actually, it was first described by Steve Charles in the 80s, and was unpopular because of low image quality, low illumination, and limited view. However, it was revived by Imai from Japan and Alan Franklin from the US, aided by the better light availability of wide field view, higher dynamic range, better image manipulation by the Ingenuity. So the technique is basically putting an exciter filter over the light source, producing blue light, filtering light between 475 to 490 nanometers to provide maximum excitation. Then you either put a physical barrier filter on the microscope to isolate the green fluorescence, or use a digital filter on the Ingenuity. So I've been using this technique for 3 years now, and it has some indications which affects the surgical decision during the surgery. But today I want to share with you what I learned over the years from using this technique and this modality during the surgery. So first, we all meet this situation where after removing the diabetic membranes, something is bleeding, a point is bleeding, and sometimes this point is over an arcade. And in spite of increasing the IOP, it is still bleeding, so you have to cauterize it. But sometimes you worry that you have occluded the vessel, the major vessel, the vein, and you don't know that the possibility that you have done actually a vein occlusion. So after doing this once, I did an intraoperative fluorescein angiography, and first the vessel was somewhat occluded. Then the blood column filled after some seconds because of the tributaries to the vein. So actually, I learned that not to be that much afraid from doing a cautery on this, but not too much, of course, over this main vessel, because it actually will find a way to fill up. Another piece of information that I got in are the ghost vessels. Sometimes you work with the retina and you see these white vessels, these ghost vessels, and you think that all of the retina is not perfused. But actually, this is not 100% true. Some of these white vessels actually transmit blood and are filled with blood, and the surrounding area is not that much non-perfused. So you take this into consideration when you do the PRP, and not do that extensive PRP over the perfused areas to let it see. Also, another situation where there is chronic RD, sometimes you see this line differentiating between what you see is retina with retinal blood vessels and some PVR, of course, and a peripheral part of the retina, which you think it looks like a dead membrane. It doesn't have any blood vessels, and you think it's useless. So I decided to do fluorescein angiography to see really if it's non-perfused and is it working or not. So it is really non-perfused, and here you have the choice either to do retinectomy or do laser on it, which I did and I chose because and using this peripheral area as an anchor. Also, in cases of PFV, the classic technique is to peel off the PFV and you cut the end of this stalk. But sometimes this stalk actually pulls retina inside it. And as you can see with the fluorescein angiography, you can see the retinal blood vessels clearly, and also you can see this small part, which is the abnormal branch from the retinal vessels going into the stalk. And here you can see exactly where you can cut, and even you don't have to do cautery. So that's a new piece of information that you can actually cut, and you can see the branch of the vessel after which you can cut safely. And last but not least, the sub-ILM hemorrhage. This is a case of a young man who had the unfortunate accident of a laser pointer injury. Here there is sub-ILM hemorrhage and something that looked like a branch artery occlusion. So he had the bad luck of hitting a branch of artery, and it bled under the ILM. So I decided to do intraocular fluorescein angiography just to document. But before that, I blew away, and this is important, I blew away the blood from over the retina to be clear after removing the ILM. So when I did the fluorescein angiography, of course, I saw the branch artery occlusion. But moreover, and that's the new part, there is a dark area around the fovea, which is not corresponding to the whole area of the sub-ILM hemorrhage. And the reason for this dark area is one of two reasons. Either there is decrease in the perfusion because of the pressure of the hemorrhage, or actually there is blood inside the retinal tissue. But anyway, both reasons made me think that I have to interfere very early in these ILM, sub-ILM hemorrhage cases, because actually there is a physical change and physical deleterious effect of this hemorrhage over the foveal area, over the macular area. And I now have evidence that there is an effect of the ILM hemorrhage. So the conservative choice is actually, in my opinion, not that wise. And after this case, I decided to promptly intervene with the ILM hemorrhage, sub-ILM hemorrhage. So in conclusion, the intraoperative fluorescein angiography is a useful surgical tool. It can provide you with crucial information aiding your surgical decision, but also can provide you with new information for future surgical decisions. Thank you.
Thank you for the great talk. May I ask a question?
Yes, of course.
We don't have an intraoperative fluorescein angiography at our clinic, but when I saw your results, I wondered that the most undesirable finding that I find at the postoperative day 1 in a patient I perform vitrectomy for vitreous hemorrhage is repeat vitreous hemorrhage. Do you really think that this technique reduces the rehemorrhage rates to
Exactly.
decide where leaks to decide the leaking area?
Yes, actually I do, and I've met a couple of rebleeds after the vitreous hemorrhage cases, and when I did the fluorescein angiography, I saw that there is extremely peripheral new vessels in these cases, and I had to re-laser them. And after that, actually, I do a more extensive and more peripheral laser. And there is also actually literature on this that the rate of rebleeds decreased, I think, by 30% in cases where they did the intraoperative fluorescein angiography.
Yeah, very impressive, because it's always a mystery where it rebleeds, because you laser everywhere, then day one you see hemorrhage. Where is it coming from?
No,
It's
yes.
easy to be sure about that. Is there any questions or comments from my
Dr.
viewers?
Habib, thank you so much for very interesting presentation.
Thank you.
Just, I got one idea. This could be very useful for the vitrectomy in cases of retinal artery occlusions, especially branch artery occlusions. If we are doing some massage technique for the plaque to dissolve, or otherwise, if we are doing some thrombectomy or something else, I think that we could see reperfusion, and it would be a very good result after the fresh surgery. So maybe you could try this. If you did not have these cases, it would be very interesting.
I will. I will. Thank you.
Yes. Yeah.
Any other questions or comments? No? Then we can go on with the third talk, I guess. Thank you.
Dear colleagues, dear friends, good morning or good evening, wherever you are. It's my pleasure to be here. And at first, let me thank personally Dr. Vaibhaseri and the friends of the Arunodaya Deseret Eye Hospital in New Delhi for organizing such an incredible international webinar. The reason of my presence, the aim of my speech, let's say, is to introduce you some tips on how to manage one of the most critical maneuvers in our vitreoretinal surgery, which is the treatment of peripheral retina in retinal detachment. I have no financial disclosure on this, and let's say the reason why the treatment of the visual space is so dangerous is at first because of the visualization, which sometimes is poor, then because often we have phakic patients, so the risk of touching the lens, and finally mainly because of the risk of unintentional retinal tears. And we know that to avoid these unintentional tears, there are some basic tips, like for example, the reduction of the vacuum in Venturi systems, or the reduction of the flow rate in peristaltic system. Here you see me working in digital surgery, as I do since almost 8 years now. And you see, and nevertheless, I'm using a Venturi pump, but looking at the numbers, the little number you see there below the IOP, which is 2.2, 2.5, this is the flow rate, the presumed flow rate. And so you know that the lower is this number, the more you are in a viscous medium, so you are in vitreous instead of BSS. And this is way of be more careful in treating the visual space. Of course, another way of avoiding tears is to stabilize with the posterior retina with perfluorocarbon liquids. But this is the way of reducing the movement of posterior retina. But our problem problems come to the dampening of movement of the peripheral retina, which is much more mobile and which is engaged when you trim the vitreous base. So how to reduce the dampening of these movements? One way is, again, to use a double cut blade, because the double cut blade, they increase the duty cycle, which means they keep the port open for a longer period. And so this means to reduce the eruption of the flow into your port. And this makes a difference. You see this example down there. On the left, you see a 10,000 cut per minute, a single cut, and on the right, the 20,000 cut per minute, a double blade. You see how the movements on the right, they are smaller and less than comparing to the 10,000 cut per minute. And the reason is, again, because a double cutting blade keeps the port open for a longer period, so reducing the obstacle to the material to enter the tip, and so giving a more linear flow. You have less repulsion of the material. Another way to reduce the movements of the peripheral retina is to reduce the infusion. If I reduce the infusion, I reduce the pressure inside the eye, and as it happens in cataract surgery, when reducing the pressure inside the eye, I will reduce this surge phenomenon which I have when the materials is engaged into the tip whenever I release the aspiration. Here again, if I reduce the infusion and at the same time I reduce it drastically up to 10, for example, like here, the aspiration, I will get less chances of having some uncontrolled material engaged into my tip. So I can go closer to the retinal surface. Moreover, if like in this case I have a beveled tip, I get closer and safer to the retinal surface, proceeding with the trimming. Other option is proceeding with the interface vitrectomy. Interface vitrectomy was firstly introduced by Steve Charles, meaning a vitrectomy done under silicone oil to reduce the movement of the retina and peeling the recurrent membranes in PVR cases. Here, the terminology is used to mean the passage between the perfluorocarbon, for example, and the BSS, as you see here. You see this meniscus, which is deformed by the presence of the vitreous. And you can better visualize the vitreous here using the steroids, because you see here the crystals of the steroids entrapped into the vitreous, so you can better visualize this remaining vitreous and proceed with the trimming. As well as you can proceed with a better trimming of the base under perfluorocarbon. If you rise up the level of perfluorocarbon up to the periphery, you can proceed with the trimming, staying very close to the retinal surface, or using even a high aspiration in a safe way, as you see here with a beveled tip again, and with a gel stained by the crystals of steroids. And but finally, what is probably the best way is under air. If you proceed, like in this case, with a fluid air exchange, the air will provide you a wider visualization, a better visualization because of the refracted index, which is different comparing to BSS. It's a lower one, so you can have a wider viewing, and you have a complete cessation of all the movement of the retina, because the retina is compressed by the air. You see here best example in this case, you see the retina which goes toward the cutter whenever you are approaching this, and you proceed with your fluid air exchange, draining all the subretinal fluid through the break, and the same way you proceed with an increase of aspiration slowly up to the base, you go up to the vitreous base. You can visualize very well because of the diffractive evidence, which is different, diffractive index of the air. You see here trimming the vitreous base, also at a very high rate of vacuum. And you see here, for example, the image. This is not an indentation. What you see there is not the presence of the buckling, there, or a circlage. It's just the vitreous base, which is trimmed again, 500 vacuum there, and completely trimmed in a safe way. But keep in mind, vitrectomy under air is not indicated in case of anterior PVR or with a bridged retina, because then you can have a subretinal migration of air, and this is very dangerous. So my take-home message is vitrectomy under air is safe and fast, very nice procedure, but has to be reserved to cases where you have a very mobile detached retina, just to avoid engagement of air under the retina, which is very dangerous. That's all. Thank you very much.
I believe Dr. Ferreira will join us later for the discussion. He's currently not available. He had shared his presentation with Vaibhav, and Vaibhav has shared it with me. So we can go on for the next presentation.
Sure. I would like to introduce our next presenter. Dr. Ahmed Roshdi is a distinguished vitreoretinal surgeon and lecturer of ophthalmology at Tanta University, Egypt. With more than a decade of clinical and academic experience, he is recognized for his expertise in managing complex RDs, diabetic retinopathy, and macular diseases. Dr. Roshdi completed advanced fellowship training at the University of California's Doheny Institute, which profoundly shaped his surgical and imaging approach. I welcome Dr. Ahmed Roshdi. Over to you, sir.
Thank you so much, Dr. Nak, for the nice presentation. And hello, everyone. Can you see my screen now?
Yes, sir, we can.
So my talk will be about scleral buckling in difficult situations. We all know that scleral buckling is a valuable treatment option for retinal detachment repair. However, scleral buckling surgery has declined over the years due to increasing interest in vitrectomy, and in some cases, scleral buckling may be superior to vitrectomy. So I will go through some difficult cases that I managed with scleral buckling. The first case is an 8-year-old patient. He's a high myopic child with anisometropia in the right eye. It was -18. The left eye was -11. He presented with hypotony, posterosynechy, and complicated cataract. And when I examined the retina, I found a chronic lower retinal detachment. There was a macular coloboma not involving the fovea, and the macula was partially detached. So the question here, where is the break? Is the retinal detachment due to the coloboma? Maybe, but the distribution of the subretinal fluid is not consistent with the coloboma in the macula. And according to the Lenkoff rules, if you have a lower bolus retinal detachment, the break is usually located above the horizontal line. So I examined the child under general anesthesia before doing the surgery, and with a scleral indentation, I found an upper temporal break. But the challenge in scleral buckling was that small breaks might be present at the edge of the coloboma. So I decided to do scleral buckling and close this upper temporal break. You can't see this break in the OPTS photo because the child was uncooperative during imaging. So we were not able to detect the break by OPTUS, but I found the break with indentation. So I decided to do scleral buckling and then inject gas at the end of scleral buckling surgery and asked the patient to do face down position, hoping that the bubble of the gas may close any possible breaks that may be present at the edge of the coloboma. So as you see here, I drained the subretinal fluid because it was a chronic retinal detachment. So here the subretinal fluid is expected to be viscid fluid, so you have to drain. You do a scleral cut down, then you do a diacerim into the choroid, then you puncture the choroid and drain the fluid. And I did scleral buckling. 4 days post-operatively, retina was I did laser to the temporal break and the temporal retina, and I did indirect laser to the area of the coloboma. But as you can see here, I didn't do laser to the part of the coloboma close to the fovea. But there was still some residual fluid in the lower retina. After 1 week, there was still a small cuff of fluid in the lower retina, but the retina was attached. So I decided to just follow up this small cuff of fluid. After another 1 month, there was a recurrent. Sorry, after 1 month there was completion. But after 1 month, the patient presented again with recurrent retinal detachment. So you can see here a recurrence of the detachment in the lower nasal area. So I found another upper nasal break. So how to manage this case now? You have a recurrence of the retinal detachment of scleral buckling. You have 3 options, either to do a vitrectomy, or to do a radial buckle to the upper nasal break, or to do a pneumatic retinal break. I decided to do and I did indirect laser to the area of the tear and the nasal retina. And here, as you see, after absorption of the most case is an 8-year-old patient with a repaired rupture. After 8 months of doing the rupture globe repair and the cataract removal, he had another blunt trauma that led to decentration of the IOL. And there was an upper localized retinal detachment due to dialysis with macula on, but the parents refused the surgical intervention and lost follow-up. They came to me after 6 months. As you see here, there is a localized upper retinal detachment, but the BVR started to happen. Here you can see a BVR in the upper retina, and there is subretinal bands. So now you have a localized upper retinal detachment with BVR, a decentered 3-piece IOL in the sulcus. So what to do? I decided to do a scleral buckling to reattach the retina and leave the IOL for another session. And here, as you can see, after doing scleral buckling, you have retinal reattachment. Retina is attached despite the presence of the BVR in the upper part of the retina. And after a few months, I decided to manage the decentered IOL. But the problem here is that the encircling buckle increased the axial length of the eye, so the biometry changed, and there was no sufficient capsular support. So I had to remove the IOL because now I have a different power of the IOL, and I decided to do a Yamani technique. So I removed this IOL, implanted another 3-piece IOL, and here I'm doing the Yamani technique and pupilloplast. And this is the Optus photo after 2 months after doing the Yamani technique and the pupilloplast. The third case is a 15-year-old patient. He presented with blunt trauma, subluxated cataractus lens, and vitreous in the anterior chamber. As you can see here, the vitreous is stained with pigments. In the fundus, there was a subtotal retina detachment due to upper temporal dialysis. If you decide to do a vitrectomy, there is a lot of many challenges here. The posterior hyaloid here is visually attached in retinal dialysis, and you may require to do a lensectomy. And if you do a lensectomy, there is a risk of telecon migration to the anterior chamber, and there is a high risk of BVR in traumatic cases. So I decided to do scleral buckling. As you can see here, retina is completely attached. And the case number 4 is a 35-year-old one-eyed patient. He lost the right eye after doing a vitrectomy for retinal detachment. He presented to me with blunt trauma, mild lens subluxation, and subtotal retinal detachment in the left eye, but I cannot detect any retinal break. So I decided to go to the OR and do indentation, and I cannot find any retinal break with indentation. So I decided to place a trocar and use the biome to do peripheral indentation and search for the break. Again, I cannot find the break. So I cannot find the break preoperatively during examination or by Optus, and I cannot find the break by indentation under general anesthesia, and even I cannot find any break by using the biome visualization and the right probe. So I decided here to drain the subretinal fluid and do an encircling band. And as you can see here, retina is completely attached, and I did a 360 laser post-operative. And the last case is a 17-year-old patient with chronic lower retinal detachment, BVR, short retina and subretinal bands. I decided to do scleral buckling, and the retina was successfully attached. If you decide to do a vitrectomy for such case, here the hyaloid is usually attached, and here in most cases you may require to do a lower retinectomy with risk of doing multiple surgery and the risk of recurrent retinal detachment. So take home message. The scleral buckling should be your first choice in pediatric patients, and scleral buckling should be the first choice in young phakic patients. And scleral buckling can work well in pseudophakic patients, even with the presence of IOL subluxation or dislocation. And if the anterior segment work is required, attach the retina first with buckle, then complete your job in the anterior segment few weeks later. And scleral buckle can work even with the presence of retinal coloboma. And the recurrent retinal detachment after scleral buckling can be managed with pneumatic retinopexy, and encircling buckle could be a good option in cases with unidentified break. And scleral buckle is the best choice in the retinal detachment due to retinal dialysis. And if you have a chronic retinal detachment with BVR and short retina, here the encircling buckle can work well as it reduces the circumference of the globe, thus allowing the short retina to relax and reattach again. Thank you so much.
Thank you, sir. Those were some amazing cases, very well documented. Do we have any questions from the panelists or the speakers?
May I ask
Sure.
a question?
Of
Thank
course.
you for the excellent talk. I'm sure that most of us would decide encircling or indentation surgery for a young phakic patient. I wonder what you think about Let's think about a 20-year-old fake patient with a high myopia with retinal detachment, one tear in the superior quadrant. Then you plan the scleral buckling, but just after you start the surgery, you find out that there's a severe scleral thinning in that area. Then how you go on? You go on with the scleral buckling, or you change the surgery and go on with vitrectomy? What would you do?
No, I will change the surgery to a vitrectomy. So if there is severe thinning here, you have a high risk of perforation of the globe during suturing. So I will just convert to vitrectomy.
Okay, thank you.
Thank you so much.
Yeah. Can I ask a question, please? Do we
course.
have time? Yeah. So in a couple of cases where you were not able to identify the break and you went ahead with a buckle and an encerclage, especially in that case, one-eyed patient who presented with a detachment in the only seeing eye. So since you were not able to localize the break even with the light pipe, so how did you determine the size of the buckle? I mean, 276, 277, where did you place it? Did you aim for a high indentation? I mean, how did you go about that case?
So I placed a 41 band without using a tire. So I just used the band, a 41 band. You know the 41 band?
Yes. The broader one.
3.5. Yes, it's a broad band. It gives you a wide indentation and a uniform indentation. So it gives you a uniform and wide indentation that can catch any possible break at the area of the oral serrate or the peripheral.
Okay.
And I go for I mean, you don't need a high indenting buckle here. You just go for a low or medium indentation, and it will be sufficient.
Okay, thank you.
Thank you, everyone. I think we can conclude this session and give way to the other session.
Thank you. It was wonderful listening to you all. Thank you.
Thank you.
Thank you. See you.
Thank you, everyone.
Good evening, everyone.
Good evening.
We welcome you to the next session. I think we're all on time. The session is the case that taught me. So we have our first speaker here. It's my pleasure to introduce Dr. Sahalve Skirtlatske, a distinguished vitreoretinal specialist from Tbilisi, Georgia, who has made a significant contribution to ophthalmic surgery research and education. He completed his medical training and ophthalmology residency at the Tbilisi State Medical University and has since enriched his skills through a lot of fellowships in Tamil Nadu, Narayan Nethralaya in Bangalore, and Munich, Germany. He's very active in a lot of professional societies, URETINA, EVRS, ESCRS. Since 2015, he has served as the head of vitreoretinal department at the Akhali Mazare Eye Clinic in Tbilisi, and he also teaches at Tbilisi State Medical University. He will be discussing a case of retinal detachment with choroidal detachment and macular hole. Welcome, Dr. Salve.
Thank you so much first of all, for inviting me. It's a great pleasure for me as a young doctor to be the part of this amazing faculty. Thank you so much. So what I would love today to share with you is a case of the retinal detachment with choroidal detachment and the macular hole, and it's called the mystery of the red snake, and we'll see why. So the case report is like a 75 years old male patient was referred to our center 1 week after cataract surgery. And on examination, the patient admitted that just 1 month before doing this cataract surgery, he had an episode of some vitreous hemorrhage, and his best corrected visual acuity was reduced. And at the presentation at my clinic, the uncorrected visual acuity was hand motion, then there was no correction, and intraocular pressure was 3 millimeter hydrargyia. And slit lamp examination revealed there was some fibrin membranes over the lens, and it was also under the lens and under the intraocular lens, and there was some tobacco dust in the vitreous cavity. and there was some choroidal detachment on the nasal side and retinal detachment with one large break that was on the 12 o'clock meridian, and there was two small breaks inferiorly. And there was also a very interesting thing. There was some subretinal hemorrhage in the macular region, and there was also macular hole. I just could not identify it was hole, but I thought it was hole because it did not have the original view of the macular hole at the just at the visualization at the slit lamp. Unfortunately, the detachment was very bullous, and I could not do the OCT before the surgery. So I started with I've done 23 gauge vitrectomy. I started here with anterior vitrectomy, as you see there, and you see there is lots of fibrin on the lens. So first I cleaned the lens from posterior side, then I moved to anterior chamber, and then I've cleaned the fibrin over the lens, and then I started the vitrectomy here. Inferior, you see there is just the hemoglobinized blood. That means that there was some blood long time ago. And here is a choroidal detachment. So this is how I drained it. I just put my trocar in the suprachoroidal space, and then I just to make my infusion high, like 50, and then I just push on the eye, and you see the fluid is coming from there. And then you can see that the choroidal detachment is gone. There is no more choroidal detachment. After this, I proceed with the staining, and I stain the macular region and the fovea. I usually stain like this. I'm sorry. Yes, and see, when I started to peel, you will see the blood came out from the fovea. So at first I started to peel with the detached retina, and then I took the Charles fluid for the passive aspiration. I put it over the fovea, and I thought it would be easy just aspirate the blood from the fovea. But see, there is this red snake. So this snake was quite big. You see now I've aspirated it quite almost the body of the snake, and when I come out of the center, you will see how long it is. See? So then I tried to do double hand technique, like there is Charles fluid. I also tried to pull it with the forceps, with the island forceps, but still not all the body was coming. So finally, I just trimmed what I could trim, like I removed just what I could remove with the cutter. And then I put the PFCL over the fovea region and for fovea detachment. And then I proceed with island peel under PFCL. I usually try not to peel close to the optic nerve, but this is not the case where I could choose the peeling site. It was a bit difficult for me to peel. So on this case, I have peeled even on the papillomacular bundle. And see, I removed the ILM over the fovea. And then I just proceed. This is the large break that was superiorly, and here is the another one small. I mark it before I go to air, and then I just go to air. I remove the fluid from the break, and you see even after some base shave, I could not remove the periphery, the hemoglobinized blood. I mean, sometimes I'm afraid just not to make iatrogenic breaks, even make the situation worse. So it's better to leave something else. Then I do just laser around the breaks, and I also done the laser. In this case, I have also done the laser 360. Usually, if I have many breaks, if I have some PVR changes, if I have some long-standing retinal detachments, I usually do also some 360 laser. I don't know what is your opinion, but in my opinion, it works well. Then I just finally I remove the PFCL, residual PFCL that was there on the posterior pole. And then I decided to put the silicone oil. And while I was injecting the silicone oil, I had some slippage of the small amount of silicone oil bubble inside the anterior chamber. So that is why I have done this inferior PI here with the cutter. I'm just cutting the iris there. And then I just finished the injection of the silicone oil. And you will see now the OCT that I have made on the second day after surgery, like this. And you will see the OCT 1 month after the surgery. And the patient's visual acuity from hand motion improved to 15 decimals, and I think he will improve after some time even more, maybe, because this is fresh surgery. And I usually remove the silicone oil. In ordinary cases, I do it for 3 months, but in this case, I'm planning to remove it maybe after 6 months. Usually, I want to check the stability and then I remove it. Thank you so much.
Great case, Dr. Shalve. Are there any questions from the panel? I have one question. Was there any history of trauma preceding?
There was no history of the trauma, so this is the interesting thing that we have seen on the OCT. There is something like a pigment epithelium bump. Maybe there was some membrane. Unfortunately, I do not have the good quality OCT angiography. I just made OCTA, but it did not give me the clue about the membrane. It was not the best one. So I'm not sure about the membrane, but maybe there was some membrane. Otherwise, there was some trauma, and because of the trauma, there was the rupture, and they gave the subretinal bleeding. But the patient didn't admit about the trauma, that this is the problem.
Yes. All right. Very interesting case. Any more questions? Okay, so we have the next moderator. Is Dr. Ribu there?
Yeah. Good evening, I'm here.
Excellent.
So,
Yeah.
yeah, it's my pleasure to briefly introduce our esteemed speaker today, Dr. Ashraf Sharawi, a renowned retina surgeon from Alexandria, Egypt. With his deep expertise and international experience, Dr. Sharawi has been at the forefront of advancement in retinal care. We are truly honored to have him with us. Let's extend a warm welcome, and we look forward to an insightful talk by him on from challenging cases. To sir, please.
Good afternoon. It's my pleasure this evening to be sharing with you in this interesting internet meeting, which is sharing all over the world very eminent professors and doctors. My talk today is about some tricks and tips during surgery, which help you should take care during the surgery so that you can have a nice outcome of most surgeries. Can you see my screen right now?
Yes, it's visible, sir.
Yes, sir, it's visible.
Okay. I'm going to share 3 cases which I operated, and I will show the tips and tricks which did help me. The first is don't splash the waters. I did call it don't splash the waters. This is 36-year-old male, one-eyed, presented with sudden drop of vision to hand motion. Examination of the eye showed a giant retinal break more than 180 degrees. A vitrectomy procedure was planned, was complete vitrectomy, including the vitreous babes and the anterior flap of the tear. PFC was injected, till flattening of the retina. Endolaser application was applied, including the peripheral horns of the tear. PFC was exchanged with silicone oil directly, which is my preferred routine other than using air in between. Post-operative, the retina was flat with improvement of vision 2.1. This is the first intraoperative appearance during the surgery. As you can see, the flap is flapped and reflected on the surface of the retina so that you cannot see the macula or the optic disc. Just you can see the choroid, the bare choroid. And this was the surgery. Vitrectomy, including deep scleral depression to remove the whole vitreous base and to remove the vitreous behind the flap. And as you go on with the removal of the vitreous, the retina starts to unfold. And then you inject a bubble of PFC in the center of the optic disc, bubble by bubble, trying to make the bubbles forming inside itself. And at that point, you just don't infuse the eye with fluid. There is no fluid inside the eye, just PFC unfolding the giant retinal break. And when you get full, complete filling of the eye, you start infusing with fluid. And as you have seen in the last part of the video, there was so many small bubbles of the PFC formed on the surface of the large bubble of the PFC, because you did splash the PFC bubble during the first time while infusing the eye with fluid. And this is a mistake. You should not do it, and take care of it. Now, direct silicon PFC exchange till the last bubble of the PFC in front of the optic disc. And then you may apply more laser to the horns under silicone oil, which is a very good trick to apply the laser under the silicone oil. It gives you a very good visibility of the retinal tissues and the area in which you apply the laser. Post-operative, this was the post-operative appearance 1 week following the surgery. And as you can see, the retina is flat. However, as you can see along the infratemporal arcades, there was a subretinal bubble of PFC, because you did splash the PFC bubble. And this is a mistake which should not do it, and you take care. I was lucky, and the patient was lucky, that this bubble didn't go all through the way under the fovea, causing this disturbance of the vision. Again, this is 1 month later. The bubble is still there infratemporally, although the fovea is attached, and the vision almost improved to 0.1. And 3 months following the surgery, again, the PFC bubble is there, no reaction, and the OST shows a flat macula. The decision now during the procedure of silicone oil removal, would you go and puncture this bubble of PFC and just leave it in peace, because you don't know the long-term effect of this bubble on the retinal tissue? The second case is about the less you do, the more you gain. And this is the case which I had been following for a long time, almost from 2018 to 2023, with increasing in drop of vision from 0.5 to 0.1. This is a one-eyed patient, pseudophakic, with the other eye had a previous retinal detachment surgery with the central macular scar. And as you can see, in 2018, this is the fovea in the healthy eye. It's very nicely reposited with no problem, and the vision almost 0.5. However, 1 year later, there was start of some cysts in the center of the fovea. 1 year later, the cysts did increase, and there was no evidence of traction. And at this point, I didn't decide to go for surgery, because the vision was good, and the patient was mildly complaining of her vision. Again, later 1 year, there is more traction, more cysts, and 1 year later, more cysts and more traction and evident traction, and evidence of the leaflet of the posterior vitreous attached to the center of the fovea, with drop of the vision 2.1. Again, this is the OST just before the surgery, and increased in the cysts, evidence of traction. And this is the composite OST showing the progression of the cysts and the traction. So this is a case of myopic traction maculopathy or vitreomacular traction. There are great debates about how to manage. Is it just by vitrectomy, detachment of posterior hyaloid, detachment of posterior hyaloid, in addition to ILM peeling, or foveal sparing ILM peeling? because there are some reports that there is no great difference between ILM peeling and without ILM peeling. And this was the surgery, just vitrectomy, staining of the posterior hyaloid with quinacort or triamcinolone, and detachment of the posterior hyaloid using a Tano scraper. And you get most of the posterior hyaloid in a single sheet up till the periphery. And I usually prefer, since I had entered the eye, I should remove the vitreous arteries. Going on to the peripheral macula now, but I have to go for more and more peeling of the posterior hyaloid. And this was the post-operative, the pre-post-operative posterior months later, the surgery, with improvement of the schisis, months following the surgery, with complete relief of vitreomacular traction. So, in my consensus, just doing less, you gain. Actually, this patient had got a vision from 0.5 to almost from 0.1 to almost 0.4. Another case which shows that you have to fight to struggle the macula, but whatever means it takes. This is a patient who had presented to me, a 35-year-old female, sudden diminution of vision. She's phakic, myopic, myopic. And this is still picture of the condition at the start of the surgery, because she had developed inferior temporal retinal detachment. And I usually prefer to go for chandelier-assisted buckling. And as you can see, the break is a flat tear down and temporal, and you have to apply your cryo, drain the subretinal fluid, place your buckle, and inject air to reform the vitreous cavity, because during the process of drainage, the interocular pressure goes down. And then the surgery just check that you have the retina flat, there is no more breaks. So this is the chandelier-assisted buckling, which helps very much in the simple retinal detachment. Post-operative, the retina was attached, and as you can see, the gas bubble was still there. This was one week following the surgery, and the buckle is there. However, 2 months later, the patient returned with this picture, PVR, complete detachment of the retina, and still the buckle was seen. And we have to go back to surgery, trying to flatten this retina, and trying to flatten this macula, peeling of posterior, even the expense of creation hydrogenic break, and near complete removal of the epiretinal membrane. I did try the new hydraulic test, in which I did do air fluid exchange just to ensure that I had removed traction. And I was lucky that I had seen that the retina was flattened, and I can apply my laser to the hydrogenic breaks and all over the buckle. And this was post-operatively, the macula was attached, however, the area along the edges of the hydrogenic breaks. 3 months later, there was more traction, and there was more formation of cataract because she was phakic. So I have to go to remove the cataract and try to remove the silicone. But there is a term we should introduce in surgery, which is silicone exchange, because sometimes the patient cannot leave without silicone. And I have to see there was severe proliferation, intraretinal, subretinal, and epiretinal. I decided to go for retinectomy and try to remove as much as I can of the epiretinal proliferation. Then injection of perfluorocarbon to flatten the remnants of the retina. And as you can see, there was along the nasal side, there was severe proliferation still. And then the retina was flattened, at least centrally. I have to apply laser all over the edge of the retinectomy. And I can see that the fovea is attached, which is my main target. This was 1 month following the surgery. As you can see, the edges of the retinectomy, the fovea was attached on the OST. And this was 3 months later, still the fovea attached. But the decision now when to remove the silicone or to go for silicone oil exchange. Actually, the patient has a visual atrophy of 360, and I don't want to lose this amount of vision. Thank you.
Thank you, sir. It's a wonderful talk. Brilliant cases shown
Is
by
it
you.
possible to congratulate this great surgeon?
Yeah.
Thank you. Thank
Can
you.
you hear
Thank
me?
you, my dear friend. Yeah.
Sir, do you have a permission to ask a question?
Yes. Do I have that?
Yes, yes, please.
If you this incredible show was a whole book. Well, not just a case, it was a teaching session that I really enjoyed. Two questions I have. The one is don't splash the perfluorocarbon. It's incredibly good because you make bubbles. And the way that I avoid it is continuous injecting perfluorocarbon through a system. If you stop and re-inject, stop and re-inject, then you might perform bubbles. So you need a continuous flow of perfluorocarbon. And if you do it by hand, it's not controlled beautifully done because then you have the bubbles. So I use a system, continuous injection system. If anybody has the Alcon machine, it has a dual petal, dual foot petal, they call it. And that's it. Half of the petal goes down and it's injecting silicone oil, and the rest is absorbing per PFCL. So when I'm changing silicone oil to PFCL, which is the right way that I'm doing, and I agree with you, this is the right way of doing in order to not have slippage, then half is injecting, and then when the pressure goes up, you go a little bit further with the second hand, and this is compulsory to have a chandelier light for these cases in order to use both hands. So with one hand, you inject silicone oil. With the other hand, you remove perfluorocarbon the same time continuously and controlling the pressure inside the eye, because you can inject as much as you want with the first stage of the foot pedal, and then you can remove when you inject and remove when you put the foot pedal down. It's a trick that Alcon machine has. I don't know if they have other people have it. And also the last case was incredible, that showed us another term that we have to put in our vocabulary, and that is silicone oil exchange. A lot of trauma cases, a lot of very difficult cases, they live in my hands at least for 10, 12 years by doing 2-3 times silicone oil exchange. And the better the silicone it becomes, the less emulsification is done. And now that I'm using only 5,500 centistoke silicone oil, that's the thickest you can have. And I have cases for 2, 3, 4 years with the same silicone oil inside without any emulsification. So thank you, Ashraf, for another teaching lesson. And we always get something from you when you teach us like that. Thank you.
Sir, I had one question. What is your take on the 360-degree prophylactic barrage laser in cases of retinal detachment surgery? The first case you showed, the giant retinal tear, was a 360-degree laser also done in that case?
Excuse me? Yeah. No, I don't believe in 360 laser. It does not make anything more. At least it makes the things worse, because actually laser can induce retinal breaks by itself. So I usually apply laser to the giant retinal break all through up till the horns, anterior horns, but I don't apply laser to any other parts of the retina, except there are visible lesions of visible breaks, because you sometimes get post-operative retinal breaks around the laser burns.
Also, they have to remember that heavy laser or heavy cryo can produce a lot of PVR in these cases, secondary PVR, that it's induced by the surgeon. If you apply a lot of cryo, for example, or a lot of laser, and this is exciting, and it produces a dilatation of the vessels, secretes subjects, that intense PVR can be done. In giant tears, PVR is much more extensive and more easy to happen because you have the choroid exposed to a great degree. So the pigment epithelium is all over the place. So I agree with Ashraf once more. Not heavy laser, not unnecessary laser. They used to say in cases that you have Stickler disease and both eyes possibly have giant tears, in the first eye to do the surgery, in the second eye to do 360 prophylactic laser. That's another story.
Okay, sir.
So can I ask a question?
Yes.
Yeah. So I just want to know, in case we are having ERM associated with subfoveal PFCL, so how to go about that? First of all, we have to go for the ERM part, or we have to drain the PFCL injected PFCL out. How to proceed in this case?
Can you repeat the question, please? The internet was not stable at this point.
Yeah, sure. Sir, I just wanted to know, in case we are having epiretinal membrane associated with subfoveal PFCL. So how to go about this case? First of all, we have to peel the ERM part and then drain out the subfoveal PFCL, or the other way out?
Well, if you have subfoveal PFC, this is another story other than my case. But you have to remove it, because on the long term, it becomes encapsulated inside a very tough capsule, and it affects the vision. So if you have membrane, in addition to that, you have to remove it at the same procedure.
Okay, sir.
And usually you do it through direct aspiration using the 41 gauge needle without the need to reapply of laser.
And which procedure to do first, sir? To peel the membrane, or to use a 41 gauge cannula to drain out the subfoveal PFCL? Out of to which procedure to do first?
I would go just to remove the PFC, the bubble, and just leave the membrane.
Okay. Thank you.
Thank you.
Do we have any more questions? So it is my privilege to introduce Dr. Athanasios Nikolakopoulos, a world-renowned vitreoretinal surgeon. Dr. Nikolakopoulos serves as the chairman of Ophthalmology Department at Papanikolaou Hospital, Greece, and is the director of the Thessaloniki Microsurgical Retina Unit. Beyond his surgical and academic excellence, Sir is also the founder and primary organizer of the TVRS, that is the Thessaloniki International Vitreoretinal Summer School. We are honored to host Sir today as he shares his insights and expertise on the topic dropped nucleus and fishing, what a cataract surgeon should avoid. Over to you, sir.
Thank you very much. I hope you can see my screen. I'm just sharing now. Okay.
Yeah.
Do you see the screen?
It's visible, sir.
It's visible. Okay, this is a case where the surgeon did everything wrong. All of us would have a cataract complication sometime in our life, depending on the quality of the knowledge and the quality of the eye. So this time, he sent me this case saying that he had a drop nucleus. And when he had a drop nucleus, it was hanging down, and then he opened up the cornea in order to put the instruments inside and remove the pieces of the lenses of the cataract that has dropped already inside. Then the other mistake is done is that he injected a lot of Hilon, of viscoat, in order to lift it up. You have to remember, if you drop something, you have to stop at the plane of the iris. You have to clean everything ahead of the plane of the iris, and then don't go fishing. This is the learning curvature that I always say to my students, don't go fishing. Don't go behind the iris for any reason, the cataract surgeon. Let everything go down and just forget of getting and capture things inside the cavity. Leave it as it is. Because if you remove the anterior part, and if you keep the anterior part steady with an infusion cannula, and the eye not to be soft, then even you can put a lens on the sulcus and leave everything behind. And then give it to us. This is our job. This is the job of vitreoretinal surgeon. We can be a cataract surgeon at the same time. But the take-home message that I always say to these cases is stop at the plane of the iris, clean everything, don't leave Hilon, vitreous, viscor inside the eye, because all these things drop down. And then, you know, the pressure the next day, you're going to have a patient who's going to have 60 millimeters of pressure. The cornea is going to be hazy. You cannot see anything. The patient cannot see anything. And he's going to come and tell you, hey, doctor, you told me 10 minutes operation and I'll be able to go home driving. And now I'm blind and painful. So to take care of that, if you remove everything from the anterior chamber and don't inject Hilon, viscoat and everything at the back of the eye, and close the eye and put the lens, the next day the patient would see a blurry vision, but would be able to see, and he doesn't going to be in pain. This is very important. The painful next day eye, it's a whole course. It's a whole system that you have to avoid. So let's see what is going to happen and why is my difficult case, the subject of this meeting is my most difficult case. Why my most difficult case is when they came to me. Let me start the video. And I hope it's starting. It's always resisting to start. Let me see what it seems to be the trouble. Okay, I'm clicking the
four-port vitrectomy. You started to find out what's going on inside the eye using the chandelier light and the 23 gauge system about alcohol plus. And we started doing the vitrectomy inside the eye, as you can see, but we didn't see any nucleus. But we saw a bull.
You see, I have to lower the voice of the video. You see that when I got in, I don't see any nucleus. I just see an inferior detachment. And that's crazy because there was a whole nucleus dropped in. Okay, let's talk through the video again.
It's retinal detachment inferiorly. So we try to detect what's going on at the bullous retinal detachment, trying to find out where is the nucleus pieces, where are the nucleus pieces. And finally, we discover that there is a large enough tear on the side and leading to an area.
What do you think produced such a kind of giant or a huge tear dialysis in an eye where he had a dropped nucleus. Fishing, going inside with a loop, trying to remove the nucleus, pulling the vitreous at the vitreous base can produce a small dialysis like that. So this is one thing that happened for the time being. But where is the nucleus?
Where it's going up to the periphery, like a small dialysis extended to the center. And but we couldn't find the nucleus at all. The pieces of nucleus broke. So we decided to vacuum the fluid behind the tear to find out if there are pieces behind it. And to our surprise, while sucking with 650, we took out with a fluid needle and we gave birth to a whole.
You see, the size of the nucleus is twice as much as the size of the dialysis. How can a nucleus, the whole nucleus, can get behind the retina from a smaller tear? And that is because somebody was squeezing the eye. If you squeeze the eye from the outside, you pressurize the eye, and then when you leave it, you have a negative pressure that can actually suck the nucleus inside the retina. That's what we thought. We became detectives.
Whole nucleus, not pieces that we thought it were, but the whole nucleus. That, as you can see, it belongs to an 84-year-old guy, and it has only the central sculpture, and the whole nucleus was intact. The question was how did it get inside, because the tear was happening, has happened because of the trying of the surgeon to fit.
Now, the difficulty, the real difficulty, you have a very hard nucleus inside a semi-detached eye that has floating retina around the nucleus. So one thing is, the question is to inject perfluorocarbon. Now, I would like to ask the panel why I couldn't inject perfluorocarbon to lift the nucleus. Anybody can give me an answer why I cannot use perfluorocarbon?
Hello, Professor. There is a
Hello.
risk to coming under the retina through the big, large tear.
Yeah.
As I go.
Things are going behind holes. It doesn't matter if it's air, if it's PFCL, if it's whatever. If the surface tension of the bubble you're promoting is more than the surface tension of the tear. So here you have a very big surface tension of the tear and very low from the perfluorocarbon. So it's certain that it's going to go through the tear behind the retina. So PFCL is gone away. So we cannot lift it actually and take it out from the anterior chamber because we're going to destroy the eye. So we have to chop it inside the eye. So we have to use macroemulsification.
Inside the vitreous to fish the nucleus, good to get upstairs. And raise a good question of how the tear happened. But it's funny because the tear was smaller than the nucleus. So how come the nucleus went in? And properly hypotony. And
so that's the second part of the difficulty. From our bad experiences, a lot of bad experiences, we never touch anything that's sitting on the retina. If I want to catch something on the top of the retina, I have to lift it first to bring it in the cavity and then try to do anything with it. As long as it's sitting on the retina, I don't touch it. Because you can understand the pressure you apply to the pigment epithelium behind it. If it's the lighter pressure, you're going to disperse the pigment epithelium behind it. You're going to have scotomas. So the second issue is you don't touch anything. So you have to do anything we want. in the vitreous cavity. That's why I'm sucking, bringing the nucleus in the middle, and then I will try to do.
Develop that nucleus. Now, the other issue is that we have to remove it without the use of PFCL, therefore carbon heavy liquids, because the tear was relatively very large, and PFCL would go there, removing as much vitreous as possible in order to access the nucleus, and do it with a manual technique by squeezing it and using the phaco and the phaco system. And we have to be very careful on that, because the end of phaco that we had is 19 gauge, and infusion line was 23 gauge. So if you're not vacuuming lens or fragments at the same time, and you go through nucleus while doing the phaco, then you go into BSS and have a sudden surge of fluid BSS and hypotony that can produce even a choroidal detachment.
Endophaco is another technique that has to be taught, has to be shown how to do it. Because if you just go next to the lens and try to cut a piece and bits and pieces, then you can go through the lens. You cannot hold the lens. So you have to make it bit by using your left hand. To use the right hand, you do the endophaco, and then you just holding the lens against the endophaco, and you produce small zaps to get inside, and you turn it around in order to keep it in the same position. Another point that I have a bad experience is you're not afraid of drops of pieces of lenses that they are throwing away to the surface of the retina. They are not capable so much to damage the retina. So don't be afraid of these pieces that they go all over the place sometimes when you drop them. Because later on, you can suck them in the middle of the eye again, one by one. But don't be afraid of that. It's much more dangerous if you try to catch them on the surface.
And that's the reason that we have to keep the other hand, the lens, the nucleus near the port every time, and to use small bursts of energy in order to keep the nucleus all the time and the port all the time closed if we can. Of course, there are pieces that are going all over the place while getting break the nucleus and get it inside. By tubing, at the same time, we have to be very careful not to touch the retina. Why is that? Because we found out to our bad experiences that we had in other cases, that if you touch anything that's sitting on top of the retina, with forceps or with fluids or whatever, the pressure you exert, you see it's not controlled, and sometimes you make breaks or you make hemorrhages, or the lightest damage can be displacement of pigment epithelium, which can produce visual impairment to this area. And you should find it in perimeter studies, microperimeter studies that we did in these cases before. So the idea and the take-home message for when you have such a complicated nucleus case is anything that has to be done, cutting the nucleus or anything that is inside the eye, you have not to press it or cut it or lift it while it's sitting on the retina. So first step is lifting, and the second step is cutting or sucking. So we have to lift everything in the center of the area that we have to work at, and then cut it with a low cutting speed in order to keep the mouth open for the vitrectomy. The low cutting speed is usually 500 and 1,000 maximum, but 500 or 800 is much better. So you keep it open much wider, and you keep it there. And the other maneuver we can do is to, while we're holding the pieces to the port, we try with the other hand to do a force feeding that is keeping the pieces to the mouth of the tip and pushing them in order to keep them stable so they don't go away when it's a cutting area. And so you see that there is limited space even in the vitreous cavity because you have a bullous detachment inferiorly you should not touch. So in order to make it more difficult, you have a floating retina while you're doing the cutting. When it's a cutting time, they used to fly away again. So if you just hold them with the other hand, it's the detachment, fixing the detachment was much easier because we can do a fluid exchange immediately. And we can remove all the fluid behind that. Like treating like a giant hair, for example, but it's not so difficult to put it back and use some laser to fix the retina detachment. And you can see here how we just put back. But another surprise was that when we finished, we found out that he had a descimate. We had a descimate detachment. By getting in and out while fishing, we found out at the end we have to put sutures through and through the cornea because it has a descimate detachment. And you know, if you leave the descimate detachment there, it's going to be a hazy eye. So in order to make it easy for us, we found out that we have to suture behind. We have to put new sutures. Gas bubble inside air, bubble inside the arterial chamber in order to flatten the folded descimate membrane. And then through and through suture through the descimate membrane of the cornea and tunnel island in order to hold it in place because otherwise it would have some epithelial damage in this eye at the end. It's very easy to fix it when you. It's very easy to fix a descimate when you do it just with one suture. But if you leave it like that, it's going to be a bit of a trouble. So it was I call it a hand grenade eye that can explode. Anything can explode in your hands. And that's the drawback and the beauty of the retina surgery, that you have to expect anything that you don't expect. And every case is a different lesson. I have cases after 35 years of operating that surprise me every time I do a case. So in order to know all these tricks and tips that Ashraf showed you, we have to teach each other what happened to us, how we face it, and I need to know your ideas about fixing cases of dropped nucleus. And thank you for accepting me to such a prestigious world meeting to celebrate the vision, the gift of vision for the humanity. I think.
Can I have a comment?
Yes, please.
First of all, thank you very much for your tips about the how to manage dropped nucleus. I have some other tips and tricks which I have learned during the time. The PFC bubble is very important to put a very small one in front of the macula because of the shattered particles during the emulsification of the hard lens would damage the fovea. So it's not just to elevate the nucleus, but to protect the fovea from the dangers of the shattering. Another point, don't ever fill the whole eye with PFC because PFC has a convex upper surface. And if you do it, then the lens will go to the periphery and its removal will be more difficult. The third trick is that sometimes you don't have phacophragementome in the OR and it's very, because it's not used frequently, sometimes it's damaged. So if you have this problem, you can go for your phacoemulsification handpiece, remove the sleeve around, and then you go for very hard nuclei and lens from the surface of the retina. And as you had said, you have to elevate the lens matter from the surface of the retina during emulsification. One final point is that if you have got descent membrane detachment, you can just put an air bubble in the AC, as our friends in the corneal surgery do right now for the ZEC and the MEC and all that stuff. Thank you for your presentation.
Thank you, Shraf.
Thank you.
Thank you, sir. That was a great case with amazing learning points. Do we have any other questions?
Do we have time for a question? I want to ask something.
Yes, we can take a question now.
Yeah, so this is for Dr. Nikolakopoulos. Sir, in your case, there was a detachment seen, but it was a subtotal, a small area of retinal detachment. What precautions are to be taken in a case like this? What parameter change, if any, that we need to do in the machine, or any variations that we need to do from a normal phaco-fragmentation, so as to make sure that the retinal detachment doesn't extend further? Because as we are doing the vitrectomy and with all that fluid going in, there's a good chance that the detachment is going to increase in size. And as it increases in size, it's going to make our life more difficult while doing the phaco-fragmentation. So are there any tips there that we can make sure that the size of the detachment doesn't increase?
That's a very good question.
Good.
Very, very good question, because I haven't thought of it myself. When it happens to get away with it, you don't think about it. But now that you're telling me, yes, there is a chance by removing things and the fluid injector to be on the huge hole that is done, the fluid that goes inside the eye, to extend the retinal detachment. And then things are going to become very difficult because you're going to be in a very narrow area to work at. So the thing is, either your infusion cannula to be not directed to the hole in order to avoid this, and you do it gradually. And then the second thing is that the machine we use for cutting this way, it's when we cut vitreous, it's very fast cutting and very low suction. But when we cut lens, it's very slow cutting and very high suction. So your indication would be at the beginning when we remove the vitreous. And the issue is that we have to remove the whole vitreous because you cannot make mobilization inside the vitreous pulling. So one way is to avoid this to go inside. The next is not to stand around. And the third thing, you have the ability, if it happens, if the fluid goes behind, to go with a suction cannula with attached to the machine and do mechanical suction, remove the fluid, because you have the hole and you can flatten the retina immediately. Not to put some gas, just remove the fluid and carry on. But thank you very much for pointing something that it happens, and I didn't think of it. Thank you for pointing out.
Thank you, sir.
Can I invite the next speaker?
No, I need to mention something, because it's the World Ophthalmology Day. You're going to see a very different area around me now, because I have to tell to the world that I moved. Hello?
Yes, we are hearing you.
We can
Yeah,
hear
you're
you.
hearing me, but you got. I have moved to France. So my permanent
Congrats,
address
Professor.
now, it's going to be in Annecy village of France, near the Swiss borders. So if anybody comes to Annecy to see the Venice of North, give me a call. Okay. Otherwise, we will be in the TVRS, Thessaloniki Summer School again. And I hope it's going to be this 29th of June to the 4th of July this year. So I would love to see my teachers and my fellows over there again. It was nice to see you, but now I have to go and pick up the kids from school because they're going to a French school now without knowing French. So that's another story. I don't speak French either. So I hope I see you here.
Can we go to the next talk now?
Hi.
Hi,
Thank
and
you.
at the onset, I'd like to invite Dr. Tatiana Vlisova, and she's a consultant for Vitretina in Saudi Arabia and Russia, and she's going to be presenting her talk on the management of retinal detachment with isolated PVR grade C. Dr. Tatiana, we welcome you to the dais, and please go ahead.
Thank you so much. Thank you for your kind invitation. Great pleasure, honor to be involved in this big World Sight Day and your conference. And I'm happy to be involved in this nice team of this session. So my talk is about isolated PVRC retina detachment, and I would just a second. I would skip the theoretical part, but at the same time, just emphasize that there are two types of subretinal bands, and we have to distinguish them, primary and postoperative. And historically, we think that the subretinal band this is the indication for vitrectomy. But we have to remember that primary subretinal bands usually develop in young patients. Long-standing retinal detachment, histologically, they consist of mature fibrocytes, glial elements, and collagen. These bands are typically inert, and they show minimal contractile activity. Several studies have shown excellent anatomical results with scleral buckling, even without any dissection of this band. And I would like to show you several 2-3 cases of patients who, for example, this patient, this is the young lady, 22 years old. She came to us without any complaints. This finding was, it was accidentally finding during ordering new glasses. She had all detachment of the left eye, fovea on but macula off, with subretinal bands, as you can see on image of OCT. At the same time, she had cataract. It was long-standing detachment, and cataract was complicated secondary cataract. And we can think about if there is a cataract about vitrectomy also, but we made the chandelier light assisted buckling. You can see the lens. It has cataract. I put trocar for chandelier, and at the same time for compensating IOP during a surgery. Drain some subretinal liquid and put. There is two big round holes that caused primary round holes that caused retinal detachment. It's a saline that we compensate the IOP and then suture the encircling band. The idea is just to change geometry of the shape of the eye, and it helps us to indent the peripheral part to block the holes, even if the patient has so many subretinal bands. Surgery was done, and the result is you can see on this slide. The retina was attached, it's completely flat, and I made the surgery phaco 1 year later of this operation, and now the visual acuity is 0.8. I put her toric IOL, but no vitrectomy, and the retina is flat. Another story of also young lady. She came very lately. She had detachment, several cysts, even in macular area. And we start with encircling band, but there was no any reattachment. And second surgery was vitrectomy. And I just want to emphasize that it's nice to have buckle before, because every time we cannot make sure that we remove all vitreous. Even we cannot remove all vitreous at the periphery in young patients, and this buckle helps us. So this strategy calls buckle first philosophy. We put silicone oil, then remove it in 2 months. There were no any epiretinal proliferation, no any PVR, and we did not remove any subretinal bands. They are in the same position, but retina is attached. This picture was done when the patient was without any silicone. It's after the surgery. Of course, visual acuity is very low, but there is the evidence that there is no need to remove all bands that under the retina. So again, this is the algorithm of surgical decision making. Remember that isolated subretinal PVR in a young chronic detachment and buckle is the best solution. If the retina is not attached, vitrectomy and subretinal band decision is a nice decision. As a conclusion, subretinal bands are not automatically indication for vitrectomy. Remember that primary bands are inert and buccal first strategy works. Post-operative membranes, it's another story. They are aggressive and need to be removal. And thank you for your kind invitation. Again, thank you so much.
Thank you, ma'am. That was actually quite informative. I still have some doubts. I mean, what is your indication for removal of this lighting? I mean, do you see it case to case, or do you prefer in young versus the elderly? Do you make a different choice? Like in young patients, sometimes we may leave these bands intact, but in the elderly, we tend to remove them at the primary surgery.
For young patients with no PVD, I prefer to do buccal. Almost always.
And about choosing to, if you have to do a vitrectomy in these eyes, would you remove these bands along with it, or would you just want to wait and watch on them?
Sorry, can you repeat the question?
If it all had to be a vitrectomy in a young patient, would you remove these bands alongside, or would you like to watch them as?
Yeah, that's why I showed. I prefer not to remove, but there is a test with PFCL. If we put PFCL and there is still tension and retina is detached due to subretinal band, it's the indication to remove it. But almost always they are inert. They happened before, and they don't. They are not the reason of retina detachment. The reason is the hole, and they are not aggressive.
Okay. Any other questions from the panel?
Yes, I have one question. Do we have time, sir?
I think so, yeah.
Yes. Ma'am, do you routinely do ILM peeling in such cases to prevent post-operative epiretinal membrane formation?
These cases do not have any epiretinal proliferation. No need to remove ILM as a source of future proliferation. It's, how to say, quite healthy tissue. No need to do it. There is only subretinal isolated PVR. And in the surface, there is the only strong adhesion of hyaloid. No need to to add intraoperative trauma. I would say like this.
Tatiana, as usually, you take all the points and you don't let any questions to happen because you have clarified everything. But one thing that in my experience has happened is that those young people with subretinal membranes and retinal detachment combined have a very long-standing retinal detachment that usually it's accidentally seen when you make a test. Have a lower vision, whatever, and they don't progress. I have a case for 4 years. He had this case 4 years, and then he left and said, I don't want to be operated. He came back 4 years later with the same exactly clinical picture. Not with, at least he had kept his vision and everything. So they are long-standing. They are produced by small holes that they are periphery because of a trauma, because of inherited or whatever. And they're completely different than the PVR that is done at the edge of a retinectomy or a very heavy surgery. It's a complete story. In heavy surgery, sometimes you have to reverse the whole retina to remove because it's like a subretinal band now. It's not a
post-operative, yes.
Post-operatively, it's a very hard situation to do.
Yeah.
And it's a very important issue for everybody to remember. As long as you have vitreous attached and you're young, vitreous is not in our hands to remove. It's impossible to remove the vitreous from a young attached vitreous patient. And thank you very much for being there. And thank you for being for us also.
Always. Thank you.
Congratulations. First week of July, don't forget.
Thank you.
I have to leave because I'm monopolizing the discussion.
I think this concludes this session. Any other comments from the panel?
I just had one question, if it's possible, just a small one from Dr. Tatiana.
Sure.
Yes. So, ma'am, have you seen any difference in the rate of redetachment of a retinal detachment? I mean, after the surgery, the retina is attached immediately post-op. But in the long run, in another 6 weeks or something, the redetachment rate, is it any different when you remove these subretinal bands or do not? I mean, have you seen any recurrences of retinal detachment if you leave these bands, or there is no difference at all?
Like I showed the
last case.
Yeah, like I showed, the last case had not redetachment, but the retina was not attached from the first surgery. But the reason is not bent. The reason is some strong adhesion and traction from vitreous first, and maybe not enough indentation of scleral buccal because of this traction, but not the subretinal bands. Because again, there are two types, and morphology of these bands are different. And these subretinal, we call it like primary, and other subretinal post-operative. These primary, they are inert, they are just under the retina. Just we can see them, and we just feel that it need to be removed. But no, even under the fovea, we will increase the trauma of pigment epithelium more than if we leave it.
Thank you.
Thank you.
Dr. Abhinav, I think we can finish the session now and let the next one start.
Okay, thank you. Very good evening to one and all. We now move on to a truly exciting session titled Extreme Cases, Extreme Measures.
And it gives me immense pleasure to invite our first speaker for this session, Dr. Raj Narayan, who needs no formal introduction. He's currently the chief of the Flom Eye Institute Retina Service at the University of Rochester, a prolific surgeon and teacher, and avid researcher with over 250 peer-reviewed publications to his credit. And on a personal note, I feel truly blessed to call him my mentor, and he has inspired countless young VR surgeons like me. So without further ado, over to you, sir, on this very interesting topic of PFCL silicone oil sandwich in complex retinal detachments.
Yeah, thank you so much, Srishti, for the kind introduction. I hope my slides are visible and I'm audible.
Yes,
So
sir.
I'll be talking about a layered PFCL and silicone oil sandwich for complex retinal detachments. This is not a commonly done procedure, but it's a useful addition to the different tools that we have currently in managing extremely complex retinal detachments. One of the challenges with rheumatogenic retinal detachment is proliferative vitreoretinopathy, leading to recurrent retinal detachments, which need multiple surgeries, and the outcome, both anatomical and visual, are not very good. At this point of time, most of the focus of retina surgery or even medical retina has been on anatomical success. Unfortunately, visual improvement is still not in our radar most of the time as surgeons, but at least anatomical success or reattachment of retina gives some hope to our patients. And PVR is the number one reason for recurrent retinal detachment. So the recurrence rates vary depending on the clinical factors, the patient factors, and the surgical methodology that has been used. But I would say in most instances, the primary success rate of retinal detachment for a simple regard is 80 to 90%. However, if there are other factors such as choroidal detachment, which is hemorrhage, high myopia, or a history of trauma, these patients have much lower primary success rate. Not to talk about those patients who already have PVR before the first surgery. A preoperative PVR reduces the reattachment rate or the success rate after first surgery significantly. And every other procedure also has more and more failure rates due to recurrent PVR. Now, PVR can be managed in different ways, but the main objective is to make sure that there is no traction or contraction remaining in the retina during the surgery, and making sure that there is adequate tamponade to the retina, both superior as well as inferior. Now, this is the challenge that we have currently. One is the recurrence of PVR, and the other is the tamponade, which is uniform all throughout the retina. So for PVR, we have different drugs which have been tried, and the recent one which everyone is taking a relook. I mean, it's not new, but everyone is trying to see if intravitreal methotrexate, especially repeated injections and not just one infusion or injection, can help reduce PVR. But again, the question of tamponade, an agent which supports both the superior and inferior retina uniformly, is currently not available. So if you take gas, it's good for the superior retina, for the tamponade, or even silicone oil. Since they are lighter than water, they tamponade the superior retina much better than the inferior retina. Or you can have heavy silicone oil or in fact even PFCL. A lot of surgeons leave perfluorocarbon in the eye for a few days or weeks, but that again supports only the inferior retina. So in either situation, you have the other side of the retina which is unsupported and has a higher risk of redetachment. So this technique of silicon oil PFCL sandwich is reserved for eyes which have extremely high risk of redetachment, and this is one example of young patient post-trauma who had retinal incarceration into the wound. As you can see here, the retina is all pulled out to one side. This is bare choroid and RPE, and the retina is like a closed flower. And then once you do all the hard work of opening up the funnel, it's easy to reattach the retina, or relatively easy to reattach once you open the funnel. This is the tough part, but once you have been able to open the funnel, you can inject PFO or silicone oil at the end of the surgery. But again, the problem comes with a uniform tamponade which supports both the superior as well as the inferior retina. So in this case, after opening the funnel and also doing some radial incisions, relaxing incisions of the retina, we managed to reattach the retina during the surgery, but these patients are at very high risk of redetachment post-operatively. And this is another young boy who had come from the Middle East, who had bilateral giant retinal tear with a closed funnel retinal detachment, where we had left the eye with PFCL, full fill of PFCL of the vitreous cavity, but after a few days, the superior retina got folded and detached, even though the eye was filled with PFCL, as you can see on the left-hand side image. This is the original retinal laser mark, but then after a few days, this retina has slipped back and folded, and this is all bare choroid and RP. And this child had to be taken back in for surgery, and this is after PFCL and silicone oil fill in the eye after the second surgery. You see the PFCL lower down and silicone oil superiorly, and this child has been doing well. So we did a study of all the patients who underwent PFCL silicone oil exchange sandwich. And the first surgery which I did was in 2013. So we had a collection of patients of more than 10 years. The number of eyes which we had done was 34, and most of the surgeries were non-endoscopic. There were just two patients who had endoscopic surgery because of bad cornea, and primary detachment with PVR was the most common indication. The second most common indication was a redetachment with PVR. Among those who had the primary surgery, most of them had significant PVR grade D with the funnel detachment. Looking at the anatomical success at week 1, which is at 96%, which is uh, expected with any surgery in retina. At 1 week, usually we have a good outcome. But then at 1 month and at the last follow-up visit, the attachment was still good at more than 90% in our patients. Unfortunately, the visual acuity did not improve very significantly because of the advanced nature of the disease in most of these patients. But some of these patients did improve to visual acuity beyond 2400 as well. So while the mean visual acuity is still less post-operatively, but some of these patients gain good vision as well. So this is the child who had a giant retinal tear with cataract. So after lensectomy and good vitreous removal around the edges of the GRT, using a dual bore cannula here to fill in the PFO, and you need to still work on the PVR intraoperatively. You have to remove the membranes extensively, make sure there is no subretinal or epiretinal membrane. And then I did laser and left this eye with perfluorocarbon. But unfortunately, as I showed earlier, there was a slippage of the retina and detachment as well from the superior retina. So as I had mentioned, the PFO is very good for inferior tamponade, but unfortunately the superior retina does not have a good tamponade with PFO alone. So then we had to take this child again for surgery, reattach the superior retina, which was folded up. And then after further laser, I left the eye with PFCL and silicone oil. And this is the outcome after a month after the surgery. And this is another patient who had a recurrent detachment. Uh, the patient already had undergone surgery earlier with silicone oil, but had PVR. So you need to clean up the retinal surface, both the epiretinal and subretinal surface, and remove all the risk factors for PVR. And these are some of the patients who can benefit with PFCL and silicone oil. So these are some of the post-operative pictures of patients who had a PFCL silicone oil sandwich. Some of them had extensive retinectomies, and the retinectomy edges are scarred, but the retina is still attached. So in conclusion, Splash is a promising option among many other options that we have. I'm sure there are a lot of questions, some I can help with, but there are quite a few unanswered questions as well with this technique. But apart from all the other options of either heavy silicone oil or leaving PFO in the eye for some time and then coming back to remove and keep them, replace it with silicone oil, our options are even intravitreal methotrexate. Those are multiple options which have their own challenges as well. But in Splash PFCL silicone oil, I've been able to leave the PFCL silicone oil for a long time, many months, and sometimes I have not even removed the PFCL from the eye. I've just left it permanently in some of these detachments. So overall, it looks like a promising option. And thank you for your kind attention. I'm happy to take any questions.
Thank you, sir, for that very interesting talk. I just had one question. I understand that you leave this in cases where it's a very dire situation. You're likely not going to go in again. But has there been a scenario where there's been a redetachment in spite of splash? And in that case, is there any challenge in removing? Ideally, they are immiscible, but I've read that it can form a sticky oil, which makes it challenging to remove. So do you have any experience with that?
Yeah, that's a very good question. I think it's extremely important to understand what Srishti has mentioned, that sometimes PFCL and silicone oil can get mixed up, and the PFCL gets the consistency of silicone oil but stays heavy. So a heavy viscous liquid is extremely difficult to remove, so much so that you just don't even attempt to remove it. But the point that you raised was about the recurrence of retinal detachment. Yes, it has happened. Um, but then these recurrences are early on. So if the retina stays attached, let's say beyond a month or two, there is a very, very low chance that they will get a redetachment after that time. So this problem of stickiness of PFCL and silicone oil happens after a few months. By the time the retina is already attached, or if it's detached, you can go in earlier as well when it's no longer, I mean, it's not yet sticky. The PFCL is not yet viscous. So the problem of a redetachment with a viscous PFCL at the same time is highly unlikely because the time points are different for the two problems. So yes, recurrence can happen, but you can do the surgery with regular PFCL silicone oil.
Thank you, sir. I think Dr. Aditya has a question.
Yeah, just a quick question. Good morning, sir. Very nice
Hi,
talk
good
as
morning.
always. So, quick question. In the first case, your dissection technique, for the closed funnel, it was interesting. So, you used a combination of forceps and scissors, or just two forceps? Because I couldn't figure out the video was sped up.
Yeah, for flat membranes of the PVR, just the forceps is fine. You don't need scissors if they're just epiretinal membranes. But yeah, I haven't had the need to have used scissors in any of my closed funnel reg RD patients. Yeah, so yeah, I use just two forceps by
Just to
manual.
open up the funnel, and then of course the rest. Okay.
Yeah,
Thank
yeah,
you.
yeah.
I have another question. Sorry. Great talk. Thank you very much for it. And I wondered if you roughly remember the percentage of patients that you could operate on again and take the PFCL plus silicone oil out.
That's a good question. Now, I have struggled with probably two patients trying to remove the PFCL and silicone oil. As a routine, like we remove silicone oil, I had planned them for silicone oil PFCL removal maybe a year down the line because the retina was attached, very nice. I wanted to remove it. I had a couple of patients. The first time, it's not always the situation, but in the first time I had it, I couldn't remove it. And then after maybe a few years, I had the opportunity to remove one more the PFCL silicone, and when it did not come out, I then realized that it's a real challenge in removing these PFCL. So I reserve it for cases where I really think that I would not be removing the silicone oil. So there are many reg RDs where we use silicone oil, but we are going in with the intention of removing them later on. But if you have a situation where you think it's going to be extremely challenging for the retina and you want to just leave the silicone oil in, those are the kind of patients where I leave this mixture in.
Okay, thank you very much.
Thank you.
Can I ask
Yeah,
you
sure.
something? Congratulations for your excellent talk. Few years ago, before the advent of heavy silicones, in Italy there was a group that actually had the same thought in this double filling of the eye. But given the surface tension of the two substances, still there is a compartment where there is no filling, and they ended up in observing PVR occurring at the edges of the PFCL silicone oil interface. Did you experience any such a thing?
That's a good question. I have experienced some eyes developing PVR, and again, you have asked a very pertinent question, and as I said, there are many questions which are unanswered in my procedure as well. So this procedure I don't think it prevents PVR. It's more of a tamponade which is uniform, but it still keeps the retina attached. The strength of the PVR forces to detach the retina probably are not as strong if you have PFCL inside. But I'm not sure if it's right at the edges which we are talking. So the PVR can be not just at the retinectomy edge, even if I have done a retinectomy, but it could be somewhere else. So I'm not sure if it's just because of the edge component that you're talking, but it could be, but it does not completely prevent PVR. You are right. Yeah. Okay.
Thank you very much, sir. If there's no other questions, we move on to the next speaker. Thank you, sir. Thank you for your wonderful talk and for the discussion. So it gives me great pleasure to introduce our next speaker, Dr. Andrew Sai, Senior Consultant in the Surgical Retina Department at the Singapore National Eye Center and Program Director of Fellowships at SNEC. Dr. Sai is a renowned surgeon and academician, and with a keen interest in pediatric retinal surgeries and over 60 peer-reviewed publications to his credit. We're delighted to have him with us today, and I invite him to give his talk on Stickler syndrome-related retinal detachment. Over to you, sir.
Thank you for the kind invitation, and thank you to Professor Sethi for inviting me. My name is Andrew Sai. I'm from the Singapore National Eye Center. So today I'm going to present one case. It's an 8-year-old full-term boy who presented with left reduced vision for a period of a month with no history of trauma. So the left eye, he was presented with hand motions of vision, and there was a posterior subcapsular cataract in the left eye as well. So this is a picture of his right eye. It shows a tessellated myopic fundus with a peripapillary atrophy. And this is a picture of his left eye, and it basically shows a total retinal detachment, the retina folded upon itself with a giant retinal tear from 11 to 5 o'clock. It's a proliferative vitreoretinopathy. So in the superior temporal quadrant, you can see that there is bare RPE. So it's a very severe condition. So the questions that we need to think about when we see this child, whether we should proceed with doing operation, the very poor prognosis, what operation should we do, and what do we do anything about the fellow eye, and whether there's any other systemic features and investigations that we should do. So additional history, we found out that he had a history of cleft palate, and he had a strong family history of retinal detachment and cleft palate. These are pictures of his father's retina, which is essentially normal. And his mother, you can see that she had retinal barrier laser done in the right eye, and the left eye, previous retinal detachment with retinectomy of silicone oil still in situ. And this is the family tree. You can see that this is the child in question. So we proceeded to perform surgery. I opted for a sclerobuccal vitrectomy procedure. So I put in a 41 band here, and then proceeded with a 3-port 25 gauge vitrectomy. You can see the posterior subcapsular cataract and a total funnel retinal detachment. You can see bare RPE. As we proceed with the retinal detachment, I tried to open the funnel. This is a monomanual technique. So after a while, I found that the view was getting bad, so I decided to perform a lensectomy as well. The priority was to reattach the retina. So I tried to open up the funnel with the one-handed technique with the light pipe as well as the retractor to stretch the, you can see that I'm with the heavy liquid, and I tried to stretch the retina, try to get it to reattach. Fortunately, I could get it to attach after doing some retinectomy. The other way would be to perform a put in a chandelier and do bimanual dissection. So you can see that some heavy liquid went under the retina. I prioritized removing it before continuing to perform the retinectomy. That just showed that the traction was not adequately relieved. If you don't relieve adequate traction, then the heavy liquid would go under the retina. So carefully reattaching the retina under the heavy liquid, perform 360 endolaser retinopexy, and eventually I inserted 1,000 centistokes of silicone oil in this child. So an inferior peripheral iridotomy was performed as well. So post-operative 1 month, he regained 2200 vision with the silicone oil in situ. The retina was reattached with no sign of further proliferation. So prior to the oil removal, that was how the retina looked. And I removed the oil at 6 months. And at year 1, he was be able to refract it to 6/18 with a refraction of +10 diopter. And I did a right eye prophylactic laser as well. So this is Dr. Bo Fenner. He's the IRD specialist in my center. I collaborate with him for these cases. So we found out that this child had the COL2A1 heterozygous mutation, and that is indicative of a type 1 Stickler syndrome, which is the more severe form. So we know that Stickler syndrome retinal detachment, that's associated with early onset myopia, wedge-shaped cataract, perivascular lattice. There's giant retinal tear, and up to 60% of this patient will get retinal detachment and bilateral retinal detachment. There may be some systemic features, and COL2A1 mutation is a type 1 Stickler's, and COL11A1 is type 2. So there's a recent meta-analysis that showed that COL2A1 mutation has a relatively higher risk of retinal detachment compared to COL11A1. And in this meta-analysis, the authors also found that 11% of retinal detachment occur before the age of 5, which brings in the question about doing prophylactic laser before the age of 5. So there's also recent work looking into the genetic variants itself, and it's found that in this small series, in the COL2A1 mutation, there was a pathogenic nonsense mutation, and that impairs collagen synthesis and therefore higher risk of RD and glaucoma, whereas in the COL11A1 it's a missense mutation, so a protein is still being produced and it's a less severe form. And I won't go into details of prophylaxis, but you can see there are multiple methods of prophylaxis that is currently being performed. And personally, I would perform the 360 indirect laser to protect the good eye. So thank you very much for inviting me once again.
Thank you, Dr. Sai, for that wonderful surgical video and talk. Since you brought up a discussion on prophylactic laser, I just want to ask you, do you do the extended vitreous-based laser sort of thing irrespective of any treatable lesions on the other eye, or only in the presence of lattices or holes?
Yes, so right now my practice is I would do genetic testing and I would perform prophylactic laser in genetic proven cases. So I laser from the equator all the way to the aura, and if there are lesions posterior to that, I would go a little bit posterior. But I mean, I understand there are many ways that people do it, and I guess more prospective studies are required to find the best, to determine the best method.
Thank you. If any other panelists have a question for Dr. Sai.
I'm curious if anyone here perform a different method of prophylaxis or do not perform prophylaxis as well.
Well, I think prophylaxis is needed. I agree that perhaps laser is the best, also because many of these lattice or say rhegmatogenous degeneration have a radial disposition. So I think that even if I was trained when I did my fellowship at Moorfields to do cryo, 360-degree cryo, I think that with laser, indirect laser, allows a more precise and sometimes more thoughtful way of dealing with those, again, radial extension of this lattice degeneration. Also because many of those are also posterior. So I do not agree with the encircling band, but there is obviously no evidence in my conviction. It's just matter of practicality. So, and I'd rather laser those.
Yep, agree.
Thank you for the wonderful talk, Dr. Sai. If there are no other questions, we'll move on to the next speaker. Over to you, Dr. Aditya.
Yeah. Thank you. Thank you so much, Dr. Surushti. So it's a great pleasure to introduce our next speaker, Professor Marcelo Casella from Brazil. And he will be enlightening us on the course of action in progressive stellate non-hereditary idiopathic foveo macular retinoschisis and how to do vitrectomy in that. Over to you, sir.
Hello, good morning. Here, can you see my presentation? I'm not seeing.
So we can see your screen?
Yes. Can you see it?
Yes, we can see your screen, sir.
Yes.
Yeah, now the presentation. Yeah.
Good. It's a great pleasure to be here, a great honor to be invited for all of you. It's a special, it's not so dramatic thing, but it's very interesting. It's a parsplana vitrectomy in progressive, severe, stellate, non-hereditary idiopathic foveal macular retinoschisis, called as sniffer. I don't know if you are aware of this. It was not very uncommon. It was, oh my God, described some years ago, not many years ago. This is a work of many people, Dr. Tamer, Dr. Remo, a lot of friends. We put some cases together. This sniffer syndrome was described in 2014 by Ober, and is characterized by stellate aspect of the macula with a separation of the macula. You have to exclude other diseases that produce this, like X-linked retinoschisis, enhanced S syndrome, myotonic dystrophy, and the others. This is the primary work from Michael Ober. At that time, they said it was kind of a benign situation with not so much visual loss. And it was characterized of this separation, and no treatment was applied at that time. But I'm going to show our first case. It was in the same year that it was described. This patient was 62 years old, was complaining of vision in his right eye. There was this splitting in the outer plexiform layer, and the other eye, there were some drusen, but normal. And you see this, you can see this very characteristic stellate pattern of the macula. And you see the separation at the outer plexiform lower in our case, that was progressing. What you could see in our case, there was no traction at the fovea, but you could identify on the arcade traction. So at this time, I didn't know this terminology. I just went to do surgery and get out of distraction. This was 2014. And used a lot of triamcinolone. And I'm going to advance a little bit. And you could see the traction exactly at that point of OCT. Going to advance. And my colleagues have been taking the ION. I just didn't took the ION in my case. I just took the traction. And let's see, you can see the exact moment we really leave. Here you can see the traction be relieved. Let's see, oh, good. Okay. And this patient did really good with improvement of the stellate pattern and improvement of the visual acuity. This is the case of my colleague Hem. He also did the surgery. He performed IOM removal. You can see here, there was a traction in the arcade also. And he did got an excellent result, but I think my father is a little bit better with the IOM. This is another case this is from Dr. Tamer, I presume. We've got 7 cases, been collecting this case. Most of them, all of them did well with surgery. This is a case that was described for a friend. Also, he performed the same surgery, but he didn't attain for the real traction. Recently, the group of Dr. David Sahaf described this syndrome. So they turned the sniffer with carpeting. That is a mid-peripheral traction. I'm not sure. With the new OCT, you can be more trustable on seed distraction. And maybe it's not sniffer, it's not carpet, it's just extrafoveal traction. And in my case, I didn't remove the IOM. If I'm gonna remove the IOM, I would spare the fovea. That's my case. And work. Thank you so much.
Thank you so much, sir. It was a very interesting presentation, and from what we understand, not too difficult to actually get it done. Or was it too easy in your hands? Maybe it's easy in your hands than us. But sir, like foveal deroofing is one potential problem or complication that can have, right? When you pull on the traction. I mean, have you ever come across actually some layers of the retina being pulled off just before, like, because we apply suction?
Yes, sometimes you can get some damage. Remo got damage in his retina, but he did some laser, as you can see in the pictures. No, I think the extraction is not so. My case was good.
These.
Yeah, our case did well, but I would not like to deroof the fovea. I would not do.
No, of course. And so no need for. Yeah. Sorry. No, just you did not need any ILM peeling or anything. It was just removal of traction, and that settled the whole thing.
Yeah. One case of 7, but the other 6 they did IOM peeling.
Okay. Thank you. Any questions from anyone? Any of the panelists?
Yes, I wonder if at the end of the surgery you leave gas and recommend the patient to do certain position post-op.
Yes, this was one unique case. I did ask him to do head position. Maybe it's not necessary. No, I did ask him to do that. I always ask my patients. I don't want to lose any patient. No.
Thank Marcelo. Congratulations.
Thank you.
If there are no other questions, then can we go to the next presentation by Dr. Francesco Boscia? And he will be explaining to us the utility of the human amniotic membrane for complicated vitreoretinal scenarios. Over to you, sir.
Thank you. I just wanted to start. Okay, can you see the slides?
Yes, sir, very well.
Perfect. So my topic is the use of human amniotic membrane for complicated vitreoretinal procedures. These are my financial disclosures. So there's been a steep rise in interest in this topic since 2019, when this was introduced into the treatment of retinal conditions. What is human amniotic membrane? Is it the innermost layer of human placenta, half of the thickness of the retina, whose use was started several decades ago, but it wasn't until 1995 then Tseng and co-authors reintroduced this tissue transplantation for ocular surface regeneration. Histologically, it's very similar to conjunctival tissue with an epithelium with secretory properties, a dense basement membrane, and a vascular stroma, which is abundant in hyaluronic acids. It is also rich in growth factors and not immunogenic, whose properties actually promote a pro-regenerative environment very similar to a fetal scarless healing. It usually easily available, comes attached to a nitrocellulose carrier and can be either fresh, cryopreserved, lyophilized, or dehydrated. The lyophilized is very easily available and affordable with easy transportation and storage and stable at room temperature. What is the relationship between amniotic membrane and retina? In vitro studies showed that it could be a useful metric substrate to retain the differentiated and epithelial phenotype of RPE. On OCT, it was shown to be integrated into the retina, allowing a partial restoration of external limiting membrane and ellipsoid zone. In a porcine model, in closing macular holes, it showed that it does so by creating an associated gliosis, allowing a centripetal migration, but not retinal regeneration. It was introduced into the clinical use by Rizzo and Kotos in 2018, and since has been used for several complicated retinal procedures. First of all, for example, is that of a recalcitrant myopic hole. This is a case I operated with ILM flap, which initially closed and reopened. So I did use a cryopreserved disc of amniotic membrane with the chorionic side down, which I positioned underneath the elevated edges of the macular hole. The maneuver is relatively simple and is usually checked with the use of intraoperative OCT. After that, just fluid air exchange is carried out because it's very stable. And this is the postoperative follow-up. You may notice how the retina reapproximates, and 2 years down the line, 3 years down the line, the retina reapproximation is almost completed. This is another case of a recurrent detachment with several holes in the posterior pole, possibly iatrogenics, with some PVR. So what I did, I started my PVR peeling under silicone, then removed silicone oil, and carried out a complete removal of all the epiretinal membranes, because even if the amniotic closes the hole, obviously the traction might actually impair all the results. So there was a bimanual removal of membrane. I stained with trypan blue the residual membrane in order to highlight the edges of the membrane, place some perfluorocarbon liquid, and again completed my PVR peeling, as you may notice, with the very well highlighted edges of the membranes. Once the peeling has been completed, I stained the lyophilized membrane with trypan blue. Again, cut with a dermatologic punch disc of lyophilized membrane, introduce it underneath the perfluorocarbon, because the lyophilized amniotic tends to fold, to roll, so you have to work manually and with the aid of perfluorocarbon. This was the first disc placed. This is covering 2 or 3 holes, and then I place a second one covering the residual hole, reposition the flap, and then carrying out the fluid air silicone oil exchange. And this is the postoperative results after silicone oil removal. You might notice that the patches are still there without sledging away. Another way of treating complicated procedure is the treatment of optic disc maculopathy, where movement of fluid causes a detachment, retina detachment. So the primary goal of this surgery is to create a permanent barrier to fluid migration. And this is one of my cases. This is a patient already operated on with a simple vitrectomy where there was a recurrence of this condition. So what I did, I used a cryo preserved amniotic membrane with the chorionic layer down and acting bimanually, carried out a fluid air gas exchange, which led eventually to a progressive reabsorption of intra-subretinal fluid. You may notice 16 months post-operatively, the retina is flat with still the amniotic membrane well in position. This is another case of the optic disc bit complicated by a macular hole. So I carried out first surgery with just ILM flap covering both the hole and the optic disc pit. You may notice that there was a reduction of the fluid, but still there was a residual fluid. So what I did, I re-entered the eye. You might notice that the ILM is still there, repositioned the ILM, and prepared two discs of lyophilized membrane, which I positioned bimanually underneath a PFCL in order to unfold the lyophilized flap both on the macular hole, and the second disc of amniotic was positioned within the optic disc pit. After having positioned the disc, I checked the correct positioning with the intraoperative OCT both on the macula and the optic nerve, and then carried out a fluid air silicone exchange. And this is the postoperative results, baseline. This is after the first surgery with ILM flap, and this is the final results with the amniotic membrane. But another, in the range of the congenital optic disc abnormalities, there is also the coloboma. This is a case of a recurrent detachment for an optic disc coloboma. First thing I noticed is that the posterior alloy was still there, so I very gently tried to remove the posterior alloy entirely from the retinal surface, obviously working bimanually. And once I removed all this membrane, I carried out a retinectomy in order to remove the subretinal silicone oil, which remained trapped after the first surgery. And once I dislocated the silicone oil, I placed this sheet of lyophilized membrane, which I kept over the coloboma by means of perfluorocarbon fluid. Obviously, I needed bimanual maneuvers in order to do that. I carried out a fluid air silicone oil exchange, and this is the postoperative results. You might notice in the red circle the hole in the intercalary membrane, which was responsible for the detachment. So in terms of safety, we didn't observe any inflammatory complication, no rejection, no IOP complication. The main issue is the dislocation, which in some series rises up to 28% of cases. This is one of my cases where I did experience this complication. Again, a recurrent detachment under silicone oil with several large hole in the posterior pole and a lot of pre-retinal, subretinal proliferation. So what I did was a retinectomy, freeing the silicone oil underneath the retina, removed the membrane from underneath the retina with a bimanual maneuver, of course, and again placing PFCL and creating a couple of discs of amniotic membrane, which I placed over the macular hole and again, replace some perfluorocarbon, second disc over the temporal holes, place the perfluorocarbon fluid. In this case, obviously, I did laser on the inferior retina, reposition the flap, check the position by means of intraoperative OCT, and after laser placement, I carried out direct fluid silicone exchange. And I was almost done, but at the last drop of perfluorocarbon, the nasal flap slipped away. So I couldn't reposition. What I did, I positioned this flap underneath the retina. So I ended up with one flap temporal side over the retina, the other on the underneath the retina. And this is the outcome. This is preoperatively. Very early postoperative with one flap underneath the retina, the other overlying the retina. And this is the final outcome with some regeneration over the retina, the flat retina. So, in conclusion, this amniotic membrane played the same role as other substrate used to close the macula, but are larger, easier to position, and more stable. Is a tissue easy to obtain to the tissue bank that rather ILM plug, autologous retina plug, or capsular lens fragment are easier to manipulate inside the eye. And further advantage over the other means of closing the macula or the retinal holes is that not only help in retinal reattachment, but also might play a partial regenerative effect, which eventually might lead to a visual acuity recovery. Thank you for your attention.
Thank you so much, sir. That was a fantastic presentation. We learned a lot from it. So just a couple of quick questions. Procuring, and of course, that would vary from country to country. But when you put it in, we saw you remove the trocar and then go in with the forceps. So you enlarge the port before you go in.
Yes, this is true only for large sheets of amniotic membrane. In some cases, you may notice that I did not remove the trocar because we're small, that is up to 2 disc diameters. Over that diameters, if they are large, you need to enlarge in order not to create pressure or perhaps break the sheet of amniotic itself. So I think very much depends on the size of the membrane you're using.
And then you scroll it up and then you put it in with the forceps. You just go directly in.
Yes, yes, I just pick it and I wouldn't scroll. I mean, I just pick it and
it
then
just scrolls on itself.
And go within. And then the unfolding is within the eye. I can tell you that the difficulty in maneuvering the fragile cryo membrane is that the chorionic layer is very sticky. So you need 2 forceps in order to remove the addition to the other forceps. So that is the difficulty for the cryo amniotic, whereas for the lyophilized, usually tends to roll and to fold, so you have to put it under the PFCL in order to flatten and better position.
And is there a correct side up or down, or you can just...
For the cryo, yes, there is the chorionic side, which should go towards the IP. For the lyophilized, I usually don't pay that much attention because it's more or less like a ILM perhaps or other material. But still, if you can keep the chorionic side down, is better.
And is it easy to identify intraop, like inside the eye, the correct orientation, or do you have any tricks for that? Tips for that?
For the cryo, it's usually it's matter of where is the sticky side. Sticky side is the chorionic side. But usually, when I pick with my forceps, I try to keep one of the branch of the forceps on the upside side. So I know that that is the upside side. Even if it rolls or it falls within the eye, I know where to find the upper part.
Okay, thank you. Anybody else with any questions, please?
Can I
Yes,
ask
I
one
would like to,
question?
yeah, sorry.
Yes, please go ahead. Yeah.
Francesco, thank you very much. Great talk. Which is the main reason for you to stain the amniotic membrane?
Because the lyophilized is very thin, is much thinner than the cryoid. So whereas the cryoid was whitish, you might have noticed that it was very obvious. With the lyophilized becomes much thinner and almost transparent. And I can tell you, especially when using on myopic eyes with a pale, say, fundi, it's very difficult to understand where you are, especially because also the holes perhaps are very, not obvious, I would say, very, very transparent. So if you stain, it's much easily maneuverable.
Yeah, I had a question. Great talk again. So in the end, I saw you mention that there's a difference in the visual recovery or the retinal regeneration between the two types of. Why do you think there is a difference between the lyophilized and the cryoid amniotic membrane?
Cryoid amniotic membrane retain all the biological properties. So it's much more, say, natural, it's much more similar to the fresh. So very rich of all the bunch of growth factors usually in the amniotic membrane bears with it. Whereas the lyophilized is more, say, is less biological active, I would say, so more an anatomical instrument of closing the holes. So in general, if possible, my suggestion is to use the cryo. But again, it depends very much on availability because lyophilized you can keep in your in storage in your theater and keep it for. I think it can last up to 3 months. So you can have it like say tenon or other tissue. With the fresh, it should be used within a couple of days.
Okay, great. Thank you so much.
Dr. Francisco, how do you approximate the correct size of the graft that you need to put inside the hole? Do you measure it?
Yes, well, good question. We usually when we enter the case, when we start the case, we already have a measure on the OCT. But I can tell you that is very, very approximate. Usually, it's we compare it with the optic disc NABED, so it's a matter of approximating the measure. But in general, I try to exceed the size I have in my mind. So if I think it could be sufficient, 1.5 millimeter, I end up creating a 2 millimeter size flap, and this goes on. So try to exceed, because if you exceed, you don't create any problem in the retina, especially for lyophilized, which is very transparent.
One last question. Now, what are your current indications in the subset of macular hole patients in whom you choose amniotic membrane graft? Is it only in the refractory macular holes, or are you also trying it in idiopathic macular holes?
Not for primary care of macular hole, unless they are very, very large in the first instance, say if it's exceeding 1500, I would think. But my first option would be also in those cases an inverted flap. But for, say, I mean, you might not have noticed that some of those cases were at several holes in the posterior pole, not only one, but there were a bunch of holes. So in those cases, I don't even try anything else. I mean, I just cover with the amniotic all the holes, and as you could see, I end up with the good results. And what is really something I can't explain, but for a biological effect, is how the amniotic works also when placed underneath the retina, which is really, I would say, magic in some respect. It's something you can't observe with the autologous retinal transplant or capsule or any other means of treating these holes. Really, and I've got several of those cases where the the amniotic membrane placed underneath the retina still works in closing the holes.
Thank you very much. So one last question before we move to the next discussion. Did you have any adverse, experiences in these cases of human amniotic membrane graft, like intraocular inflammation or raised dioptry post-surgery?
I'm not sure I understand. If it was to me, I don't understand the question. Sorry.
Did you have any adverse, like intraocular inflammation in the post-surgical cases? Any such experience?
No, not at all. Not at all. Actually, it was found, obviously I didn't show, but it was found to be not immunogenic. And also when removed from the eye, it was examined. There were no markers for lymphocytic or lymphoid reaction. So definitely it's a tissue which might be used with the confidence also in that respect. It's not immunogenic at all.
Thank you.
Thank you so much, everyone. And it was a fantastic session, lots to learn for all of us. And thank you, Dr. Sankeet, Dr. Srushti. And if there are no more questions, then I think we can hand over the session to the next set of moderators and speakers. Thank you once again, everyone.
Thank you.
Thank you, Dr. Aditya. Good evening, everyone. And we'll start this next session for today. I'd like to invite our first speaker, Dr. Alejandro. Dr. Alejandro is based in San Miguel, Argentina, and he's the head of the Retina and Macula Unit at the Center for Ophthalmic Specialties, and he's also the president of the institution. And he's traveling today to Panama City, and still he's very kindly agreed to be a part of this. And thank you for being here, sir. And I hand it over to you to start your presentation for us today.
No, thank you very much. I want to show you today how we deal with fresh retinal detachment, paying special attention how to address the periphery of the retina in those cases. We use this sequence for reattachment the retina. As we always do, the first step is the vitrectomy. Second one is to assess the posterior hyaloid. We always want to detach it just to assure that the retinal will reattach properly. And then we inject some perfluorocarbon liquid in the vitreous cavity. And then we do the peripheral shaving of the vitreous base using an scleral depressor self-illuminated. We'll see it in the video. And then we finish the surgery performing the endo laser. I will show the surgery of this particular case, which is a fresh RD with a relative big hole, temporal and superior in the retina. And the macula is compromised in this particular case. So we start the vitrectomy with a core vitrectomy, just trying to remove as much vitreous as we can. We usually, in this part of the surgery, go up to the middle of the periphery and then assess the presence of the vitreous in the retinal tear. Then we try to pull up the posterior hyaloid. We can use triamcinolone, but in this case, it wasn't necessary. And then we apply perfluorocarbon liquid probably up to the posterior border of the tear. And then we use this instrument that we find it is very useful. It's a self-illuminated scleral depressor, which allows us to have an extremely clear view of the periphery, and it is easy to perform a very close shaving of the vitreous base. So when this part of the surgery is done, we do the same in the tear. we tried not only to remove the flap of the tear, but also tried to cut the retina further up to the periphery, making something that we call a radial retinectomy from the tear to the periphery. And this allow us not only to perform the removal of obstruction in the flap, but also to cut the vitreous base and release traction in this area. And what follow when after removing all the traction is performing the endolaser, and this is usually a 20 minutes surgery. We end up in general with a good result like this. So we think that what feels particularly important in this surgery is how we manage the vitreous base with the pressor, illuminated depressor. With a good magnification, we always get a clear view of the periphery. Sometimes you can find blood there, and it's marking the presence of vitreous in this area. So depressing, we can also see extremely small tears like in this area, in this detachment. So we feel really confident using this illuminated scleral depressor that we can remove all the vitreous and also the traction. So this is the sequence that we usually use in these fresh RDs. First of all, vitrectomy, of course, assess the posterior hyaloid, partial peripheral carbon liquid injection, and again, what we can consider particularly important is the extremely well shaving of the vitreous base, and all of the cases end up with the endolaser. So this is everything for today. Thank you very much.
Thank you very much, Dr. Alejandro. I just have one question to ask. Is PFCL injection something you do for all cases, even if it's a macula on detachment?
Good question. Probably not. If a macula is on, I will try to avoid the use of heavy liquid because probably it is not necessary. And what I will try to do in this particular case is where the scleral depressor depress where the tear is, and with the vitreous probe in the other hand, try to aspirate the supraretinal fluid. And almost always is feasible to do that.
If any more questions, or we can proceed to the next talk.
Hello, sir. Good evening. Excellent presentation. I'd like to ask, how do you approach if there are multiple tears? So do you do a lot of retinectomies throughout the retina? And secondly, if we are doing that, won't it create a lot of chances of proliferative vitreoretinopathy and further redetachment?
Kunal, thank you very much for your question. I found this very interesting. If I have several tears, probably I will pick up the larger and the more peripheral one to do the radial retinectomy toward the pars plana, just in one of the tears.
So what forms the basis of this retinectomy? Why do we need to do the retinectomy? Why not just shave the peripheral vitreous base there? How do you find it better than shaving this?
I think what makes the difference making the radial retinectomy toward the pars plana is that doing that you cut or you split the vitreous base, probably getting a better relaxing effect in the periphery of the retina.
And there are no chances of increased PVR when we do it, when we're doing a larger retinectomy?
we didn't see more PVR cases since we start doing this.
Great, excellent technique. Probably we should try it.
Yeah, thank you, Kunal. Let me know.
Oh, sure, will do.
Thank you for that interesting presentation. I now call upon our next speaker for today, Dr. Zinnik. If you could please share your slides, sir. So Dr. Zinnik works at the University Eye Clinic Novi Sad, and apart from being a retina specialist, he's also done his doctoral research on macular structure. So he has a special insight to macular pathologies as well. And he'll be presenting his cases on SF6 versus air tamponade on retinal detachment surgery. All over to you, sir.
Hello, good afternoon. Thank you very much for the invitation. I would like to address the states if there is enough to actually to change or to substitute the SF6 for the selected retinal detachment cases. Just a second. Can you see it?
It's stuck on your title slide, sir. It's not moved to the next slide.
I'm just trying to move it, but it doesn't go on.
Maybe you can unshare it and share it again in the slideshow mode. That might work.
In just a second. I'm sharing it. Okay, let's see like this. It's not, sorry. Now it's going.
Yes, it's gone. You can see it.
Okay, so we have a different type, of course, of retinal detachments. So depending on the types of the detachment, we can discuss the different approach. What is actually in common is that the pars plana vitrectomy can be actually accomplished or can reattach the retina in most types of the surgery. Our algorithm for when we approach to the retinal detachment, it actually depends from the age of the patients. So if the patients are younger, so less than 30 years old, we'll try to do either segmental or scleral buckle. Between the 30 and 40 years of age, we usually proceed with vitrectomy. And after the 40, in general, we are thinking of combining it with a phaco. For sure, it's much easier, of course, to clean completely the vitreoretinal and to shave the vitreoretinal base when comparing to so-called spare vitrectomy. What is the primary, actually, when we speak about the primary vitrectomy, it's all the cases of pseudophakia, when the tears are located posterior to the equator, in the cases of giant retinal tears, or opacification of optic media, and of course the PVR and the long-standing retinal detachments. The main goal of all of the procedure is to try to reattach the retina only in one surgery, to have the procedure with a minimum comorbidity. Of course, the outpatient surgery, the setting by a workforce, so the patients are leaving a couple of hours after, and it's not to do any kind of secondary complication. Our approach in pars plana vitrectomy is so-called dry out technique, where we, after the central vitrectomy, induction of the PVD, really very rarely induce the PFCL, only in selected cases, but in a straightforward retinal detachment, almost never. Then we use the peripheral shaving, of course, with indentation, fluid air exchange, and the laser photocoagulation, depending, first of all, around the hole, and depending on the site or the periphery of the retina. In some of the cases, I use prophylactic 360 degree. Usually in our setting, we decided to either to put the air or to put the silicone oil in long-standing. This approach of dry out technique actually provides us much better visualization comparing to some others. So when we remove the vitreous and reattach the retina, then what to put inside?
We have, of course, the air, which is non-expansive, which lasts up to the 1 week, couple of 4 to 5 days. We have a different type of gases, depending on the concentration and the type of gases, which can last for up to 2 weeks to even 6 to 8 weeks. And of course, silicone oil. When we speak about the gases, we have some pros and cons for the gases. Of course, the pro is that they provide a longer tamponade, and it can be also used in some selected of the PVR cases. But some of the other, let's say, contrast stuff to use the gases in some cases is that they can induce elevated intraocular pressure. We can make the sight-threatening GAX mix errors. Of course, the cataract formation and inadequate size of the Babel gas, and of course it lasts for a little bit longer position, a little bit longer prone position. Comparing to the air, the air is the duration actually is most let's say backwards of the using the air, but it's very fast. It doesn't induce the elevation of intraocular pressure, no kind of any mixture of the error, or very less or even no cataract formation. What we think is that even when you do the closer and the first laser photocoagulation, in some selected cases, air is quite enough to hold the retina in place, or to make the adhesion. Actually, the retina likes to stay at its places. So if you move all the vitreous, all the things that are actually pulling the retina back, air will be sufficient after doing either the laser or the cryo in order to hold the retina back, or to hold the retina at the position. So we follow up like the 27 eyes with the retinal detachment surgery, with retinal detachment, which lasts up to the 3 weeks. It was one or multiple holes with the grade. In some of the cases, it was the grade PVRA or B, with 18 eyes were combined with the phaco, and 9 pseudophakic eyes. In all cases, it was dry out technique, and the follow-up period was 1 year. Our standard technique, so we use like the 4-port system with Ingenuity and 25 gauge vitrectomy. After complete doing the central part of the vitrectomy, we induced posterior vitreous detachment. In most of the cases, usually Ingenuity provides very good visualization, but in most of the cases, I usually like to put either triamcinolone on the trypan blue than the dyes, just to check and to be aware if I remove all of the posterior hyaloid, or to remove all the possible traction which can lately cause either the PVR or cause the retinal detachment. And after that, I proceed with the meticulous shaving of the vitreous base using I'm indenting for myself, as I'm using for 4-port. And at that point, I think that it's really very important to try to clean as much as possible, because all kinds of leftovers of the vitreous, especially if you leave the air at the inside the eye, can lately cause to retinal to really detach again. So after complete cleaning of the vitreous base, I drain the subretinal fluid throughout the pre-existing hole, usually using the soft tip, which is connected to the machine with an active aspiration. And then I perform the laser photocoagulation around the hole. I check up the periphery, and as I already explained, that in some of the cases, I usually do the 360 prophylactic laser photocoagulation. Concerning the subretinal fluid at the posterior pole, which is usually collected, I don't take care about much of that, because if you close the hole and if you close everything, it will reabsorb even in a 24 hours, because the air will usually go up for 24 hours. It would be you can see in most of the cases the retina below the lower arcade. So
in the small case areas, in all the retina was the successful surgery was performed in all of the cases. In one case where we have the retinal detachment as a complication of the anterior segment surgery, which lasted 3 years, we got the PVR case, so we have a redetachment of the retina, and we have a one hypotony in a myopic eye, and all patients stay quite stable during the follow-up period, so the retina was attached. So we thought that air tamponade can really, in some of the cases, can change the SF6. It's very easy, it's very quick, and it's low cost. During the technique, you just leave it. But for sure, especially in primary non-complicated the cases, for sure for all the upper quadrant, there are some recent publications. I mean, for a long time, that also in the inferior part. We tried a couple of cases and it also works, but you just have to be sure that you clean everything very carefully. Thank you very much for the attention.
Thank you for that interesting presentation, Dr. Zinnik. I had a couple of questions for you. Number one, I noticed that you did multiple rows of laser around the break in the case you showed. So in the cases which you plan to close under an air tamponade as opposed to say a SF6 or C3F8 or oil, do you do some additional rows of laser around the break in those eyes, or is it the same for all of you? Yeah. For all
I usually maybe like to add to a little bit more of the laser, to put it like between 2 or 3 rows. It makes me more confident.
I do the same.
It's usually the way I work. So at least 3 rows.
So it doesn't change based on the air tamponade?
No, I didn't change any kind of any differences.
And my second question to you is that sometimes with air, especially when we don't suture it, and in the Indian context, we do reuse our trocars. I don't know how it is for you. So does it happen that like when the air leaks out, and you did mention an inadequate air bubble size, and the air might leak out and get out faster. So would mixing a suboptimal concentration of SF6, like just a 5% or 6% to make it last a little longer help? Would you try that?
It can be an option. I thought of that, especially in that one case when we have a myopic. So the air absorbed a little bit faster comparing to the fluid. So we just add it. So it can be really a solution, but also in a myopic cases. But for sure, you need to be sure that the sclerotomies are closed, that they fit. And of course, it depends on the usage of the trocars. Yeah, but I completely agree.
And my third question for you is that in the cases you presented, all of them were, I think, pseudophakic cases, or the phakic ones were
the pseudophakic, and the cases where I did not with the cataract, I do the combined procedure. So it was not the I didn't present the cases with a lens.
Have you done these in cases where the lens is intact, where you've only done a vitrectomy without combining it with phaco, or in your practice do you routinely combine the cataract surgery with vitrectomy?
I usually like to combine it, but usually in selected cases I leave the lens, because there's the borderline between younger. But when the people are around 40, for sure it will be something with the lens, and I can clean it. I think I can clean it much more better, especially if I want to make it to finish it with the air, even with the gas. I mean, but I have to be sure that they clean the base completely and correctly. And
I absolutely agree with that.
Much better without the lens.
I absolutely agree with that. Thank you for those points, sir.
Thank you.
I think Kunal sir has some questions.
Yeah, Dr. Zinnik, excellent presentation. I just want to know when would you like to use a tamponade? What is your cutoff that here I would like to put in a gas or an oil, and here I would like to be just with the air?
I usually put air in all of the cases when I have the upper the holes in the upper quadrants, even in some selected in the lower parts. Otherwise, I put silicone oil. Somehow I feel much more comfortable to put silicone oil instead of C3F8, for example, for long-standing gases. So it's just a matter of when I see the patient, how the retina looks, if they move the grade of the PVR and everything. So either the air or the silicone oil. When I have the borderline cases, I put the silicone oil.
Great, great. So, any more questions from the panel?
I just had one additional point to ask Dr. Zinek. For cases with inferior breaks where you put a air tamponade, so there's a technique called the guard technique and fibrin glue used for retinal detachment. It's been promoted by Dr. Tyagi from LV Prasad Eye Institute, and there's also work on it by a group from China, where you use fibrin glue as a tamponade over the break to keep it dry. So would you consider that as an additional step to do for cases with inferior breaks, to help keep the break dry while the effect of the laser takes up completely?
I saw it. It will be very interesting. Unfortunately, I have no available fibrin glue in my country.
Thank you, Dr. Zinek.
Thank you.
Okay. So now we move on to our next speaker. I would like to introduce Dr. Mohammad Tawfiq. He's a very dynamic surgeon and he's a pan-ophthalmologist. He's not only he's doing vitreoretinal surgery, he's also a refractive as well as a phaco surgeon. He runs his own center, Tawfiq Eye Center, and he's practicing in Cairo, Egypt. Over to you, Dr. Tawfiq.
Hi, how are you? I am happy to being with you. I will just add a small tips after my friend is doing a great presentation. And I just shared the video. It's done now?
Yeah, it's visible.
So it will be a couple of retinal detachment cases to show the technique in different scenarios of cataract surgery, of fresh retinal detachment surgery. This is my way of I have a fresh retinal detachment. Very straightforward, minimal vitrectomy. I didn't do a complete vitrectomy, fresh retinal detachment, sclerotomy insertions, and do achieve vitrectomy. If you know 90% or 95% of the cases with fresh retinal detachment, even if you have a bullous retinal detachment with short tear, the BVD is there. So you just go for complete vitrectomy, pseudohyaloid detachment, and directly to the break. Release the vitreous attachment over the break, fluid exchange, and can accord check there is no pseudohyaloid. Be stuck on the vitreous over the break, direct fluid exchange from the break, even if the break is anterior and is anteriorly, by head positioning of the globe and the head tilting of the patient. Make the break in the most bendant part. You can squeeze all the subretinal fluid through the break without PFCL, without drainage or tenotomy, and laser only the break. If you didn't be sure that there is no break 360. And also, if you have a small subretinal fluid in the posterior pole, never mind, leave it and put the patient on air. You don't need an upper retinal detachment to put the patient on SF6 or silicone oil. By the way, I have the clue that you must have air and silicone. Or if you need to do gas, you need to use a long-standing gas, not an SF6. SF6 for me is like an air. There is no difference for SF6 and air. This is a phakic eye. Again, just curve vitrectomy, anterior vitrectomy, check for the posterior hyaloid and go directly to the break. Release the vitreous attachment from the break. Fluid exchange, and when the retina become flat, go for air. Don't go for air first. Make a fluid exchange and dry the retina as much as you can, and make the air do the next job, flattening the rest of the subretinal fluid. If you see some vitreous around the break, on air, release it. Just sit around the break. You don't need to go around 360 and remove all the vitreous attachment. Just sit. Laser of the break, drainage of the subretinal fluid directly from the break, and leave the posterior pool even if there is a subretinal fluid, as you can see here. Just laser the break and go on air or silicone. Never mind. Again, this is the fresh retinal detachment. As you can see, when I complete the vitrectomy, I directly go to the break. Be sure that there is no vitreous attachment over the break. Fluid, and then fluid air exchange. Put the air, make the air pushing the retina back to the sclera, laser, and at the end, we remove the fluid over the disc, even if there is a bolus fluid in the posterior pole. Next day, post-operative, the posterior pole will be flat. And also, sometimes in the scleral rigidity, if you leave the patient on air or gas, you need to suture it to keep the glue pressurized by air. If you have a two-horse short air, I suggest to open this two-horse short air together to make no connections between the two holes of the two breaks. And the same technique, I will never use the PFCL in fresh retina detachment. Never use it. Even lower detachment, upper detachment, nasal detachment, temporal detachment. I go directly to the break, aspirate fluid, and then go with air, remove the subretinal fluid, keep the rest of subretinal fluid to the RPE to aspirate it for the next 24 hours. As you can see, even when I go to the ear and see there is a subvitreous attachment around the break, there is a subvitreous attachment around the break. I use the vitrectomy under ear to shaving the remaining vitreous around the break. If you have a anterior break, you can use the chandelier, and by indentation, you can reach to this very anterior break. And as you can see, also with our PFCL, you can drain the flow by positioning of your left hand, if you indent by your left hand, and very gently keep the break open as much as you can. Don't flat the break eerily. Try to keep the break open as much as you can to drain as much as you can the subretinal fluid without using the PFCL. And as you can see, I drain all the subretinal fluid by indentation and use the indentation to usually open the break and drain the subretinal fluid from the far anterior peripheral break. Laser, keep the patient on air or SF6 or gas. As you can see here, I just check it if there is a vitreous attachment by probe. This is also, again, the peripheral detachment with peripheral break. I shaving the vitreous around the break, and by indentation, I try to keep, as you can see here, I try to keep the lower edge of the break open to drain as much as you can subretinal fluid from the break. So don't flat the break eerily. Keep it, the mouth of the break, keep open to suck the fluid underneath the retina as much as you can without need to use the PFCL. In such type of cases, I never used ILM peeling. I didn't need to use ILM peeling. I didn't do a complete vitreous shaving. I just check it if there is a peripheral missed break or another break. Didn't see it in the examination. Just deal with the pathological vitreous over the break and don't do much job more than what we are seeing now. Just fluid exchange, complete with air drainage from the break, leave the subretinal fluid to the retina pigment epithelium to do the rest of the job. So this is my technique in a fresh retina detachment, even upper or lower fresh retina detachment. I didn't do anything more than what we can see now. So this is the fresh retina detachment. But if you have a large retina detachment, large break like this, I think it's 4 or 5, 6 clock hours. No way of using the PFCL in such a situation. So the PFCL in such cases is a mandatory. Just clean the vitreous, do your job, and complete the glue with the PFCL, and laser the break under the PFCL, and then do fluid air exchange. As you can see, I complete the glue with the PFCL by indentation or laser the peripheral breaks, and then do the fluid air PFCL exchange and leave the patient on silicone oil. So it's not an strict way of your job. It's different according to the situations of retina detachment. As you can see, this is a large break. So the PFCL in such a situation, it's mandatory. I think you cannot do the job and you cannot flat the retina directly by air use. As you can see here in such a large detachment with a very large break. It's around 5 to 6 clock hours break. Yeah. This is the final result and when we checked for air. If you have a detachment with a PVR, posterior PVR, I recommend you to remove the membrane. If you have the posterior PVR, you can remove the membrane. And in such situations, you need to complete the job because it's a chronic detachment with a proliferation. So now we don't have a fresh detachment. You need to be confirmed that the ILM is removed, to be confirmed that the posterior pole is clean. So I didn't use the ILM peeling in a fresh retinal detachment, but in such situations, I used the ILM peeling and be sure that all the posterior pole it's free. I removed ILM peeling to prevent another PVR remover. So it's such a situation, we do ILM peeling. Also in the lower chronic retinal detachment, as you can see in this case, if I have a chronic lower retinal detachment, my way of is PVD. And also the new lesson for me in such type of cases is a buckle effect, by the way. If I have this case now, I will do buckle. I didn't do the vitrectomy in such a situation, but this is the case. If I'm going for the vitrectomy, I directly go for the retinectomy. So I never keep this stretched lower retina in such a situation. I relax the lower retina, peel the ILM because it's a chronic retinal detachment. We have expected recurrence with the PVR, so I remove the ILM in such situations. And also I do lower retina retinectomy to relax the lower retina because we have a shortening. So what the buckle is doing, I do it by relaxing the lower retina. But also, I strongly believe that in such a situation, especially in non-BVD retinal detachment, the buckle alone is the good choice for such a case. But if you're going for the vitrectomy, I strongly advise you to, in the first surgery, relax the lower retina. Don't try to do like keeping the retina and make the silicone flat your retina and keep the retina. In the first surgery, relax the retina and do the lower retina because the retina have a shortening, definitely shortening. And also do the 2 radial retinectomy, make the circumferential shortening and anteroposterior shortening relaxed. So do the lower retinectomy 180 degree and 2 radial retinectomy to relax the circumferential shortening. So if I have a lower chronic detachment, I do like what you're saying now. I relaxing the lower retina 180 degree and also do the radial retinectomy to relax the circumferential contractions on the retina. You can see now I just do complete the lower retinectomy and go directly radial to relax the lower retina. You see, it's stretched circumferentially. So before I complete the PFCL and flatten this posterior retina, I cut it radially to relax it circumferentially. As you can see here, this is what I'm doing. And when we relax it radially, so you decrease the circumferential contraction and decrease the anteroposterior contraction. And this is lower retina now has become free. You flatten the PFCL. And believe me, if you do this, you do not need to go for direct PFCL silicone exchange because the retina is now free and it's never stretched on the horn, in the 2 horn. So do the radial retinectomy in lower recurrent retinal detachment. So this is a couple of cases of retinal detachment from fresh retinal detachment, and we do a classic straightforward vitrectomy without doing extra job, to the posterior PVR cases, to the chronic lower retinal detachment, to the large peripheral retinal tear. So I think I try to collect some tips and tricks in a retinal detachment case.
Great presentation, Dr. Topic. I have a couple of questions. So one, why not the base dissection? As Dr. Alexandra was telling us that you need to have a good base dissection over the break and probably a retinectomy also. Why not doing the base dissection over the break? Do you think?
Yeah,
the vitreous base dissection.
vitreous-based dissection, I strongly believe that there is no rule of vitreous shaving. You need to remove the pathological vitreous. You didn't need to remove the whole vitreous. You need to remove to induct the posterior hyaloid detachment if there is a attached posterior hyaloid, and we go for the pathological vitreous to remove it. There is a vitreous attached to the break. Release the vitreous around the break, and the rest of the vitreous, we didn't need to do it. You complete the vitrectomy, but you didn't need to shave everything. You didn't need to go for the periphery. By the way, I have a strong belief that the strict complete vitreous shaving increase the incidence of missed break.
And so when you do a fresh RD with this technique, what are your chances of redetachment? Have you checked your numbers? How many patients are redetaching, or were all the patients completely attached?
I think 1% or maximum 2% of redetachment. But all of us, as a retinal surgeon, have a clue that if the retina need to redetach, it will redetach even whatever you do anything, by the way. And you are totally agree about this. You have a case, you do everything, and post-operative have a redetachment. And in another way, you feel that you never do anything and the retina is still attached. And what will happen, you don't need. So for all of us, I feel that we don't have the strong point why this retina is redetached again. You have the answer?
I don't have the answer. I thought you will be having some.
So you just do what you believe in according to your surgery. You do audit about your surgery, So if you have, like the last year, a couple of detachment cases, and you do what I'm telling to you, and you feel that 90% of the cases is redetached, you will complete what I'm telling you to do. You stop. This is the importance of auditing. You audit about your surgery and you see the results of your surgery. So what I'm doing, it's going perfect in the results, or we have a problem. Believe me, I have a lot of complications from PFC using. PFC under retina, PFC macular hole, PFC. So I feel that there is no role of PFC to drain the subretinal fluid. And also, in the past, I never leave the patient if I strongly believe that the subretinal fluid is dry. I feel that the macula is totally flat, so I finish the surgery. Now I can leave the retina pulless like this. If the break is lasered, I'm done. If the subretinal fluid is there, leave it. Second day post-operative, it will be flat. So you see, every year you check it to what you are doing. Every year you collect your cases, you see your results, what you are doing, you need to adapt it or you need to change it,
Interesting. So very interesting minimal vitrectomy tips we have got from Dr. Tawfiq. Any comments from Dr. Alejandro?
Yeah, Mohammed, thank you very much for your talk. It's very nice to see you again.
Thank you.
I have a question for you. Which is your clinical surgical sign when you decide to start the fluid air exchange? Because you show beautifully in your video that you aspirate with the catheter the subretinal fluid through the break, and at a given point you decide to start the fluid air exchange. What do you see, or what is your clinical sign to decide where to the air enter in the eye?
By the way, this step is testing the freshability of the retina, So if you go for fluid exchange, if you have a pullous retina detachment and the retina is flattening more, this retina is fresh, definitely fresh, because if when I aspirate the fluid, and the fluid pushing the retina and the retina has become flat, this means that retina is fresh. So what I'm doing is going to release the vitreous attachment over the break, fluid exchange, and if it's stopped to become more flat, this is the time for air. So if it's going more flat, so if I stop at the level, this is the time for air. So I keep fluid exchange until we stop in the level. in the level if the retina does not become more flat. This is the time for here. And also, if it is anterior flap, anterior tear, and I need this tear is open as much as you can to complete aspirate the rest of posterior fluid. I starting to head positioning of the patient and tilting the eye with the trocars to make this break in the most dependent part, and then start the fluid exchange.
Okay, thanks. Thanks, Mohammed.
I just have one question, Dr. Mohammed. Excellent surgery, by the way. Just was superb to see your surgery. Am I audible?
I never hear the question.
Yeah. So my question is that you are drawing with the cutter. You are doing the aspiration of the subretinal fluid or the fluid with the cutter. So have you encountered sometimes that when you are doing it with the cutter, you still have a bleb of fluid left subretinally behind? If you would have done the aspiration with a slower rate with the help of passive aspiration or something. So there's like
I understand the questions because if you use the passive aspiration, you have a control of aspiration of subretinal fluid. If you're going with active, the break will dry faster than if you're going with passive. This is your questions, I'm right?
Yeah.
So you can control this with your foot pedal. So I'm using the foot pedal, controlling the aspiration very carefully. But if you didn't able to control this with your foot pedal, your way is perfect. Go with a passive, because the passive is the best way to control aspiration of subretinal fluid and make the break dry at the end. So the break never dry faster if you're going for passive aspiration. So I totally agree with you.
So I personally feel that if when you are doing a retinotomy and you're not using a peripheral break to draw the fluid, so in my hand the passive works better. If I created a retinotomy, then an active one's faster. So it depends. For me, if I am like, I also do what you do is I also shift the head of the patient, trying to make it more dependent. But then if I use passive, I really ensure that no fluid is left subretinally. So although, as you rightly said, that on the next day that will go away, but it's better to have a complete flat retina on table than waiting for tomorrow.
This is the controversy of is it better to leave the retina flat or to leave some subretinal fluid. What I'm seeing in my auditing, there is no difference if we keep the retina flat or we leave some subretinal fluid. The only point that I'm seeing is the retinal shifting. If I have like a upper pullus detachment in the macula, and the fluid is not complete in all the macular area, it's maybe like a fold or retina slippage, like the visits of the retina is slipped. This is the only problem I face it if if I leave some fluid underneath the macula. So if the macula is partially detached, I try to keep it more flat. If the macula is totally detached and the posterior pole detached, there is a subretinal fluid in the posterior pole, leave it, whatever the size of detachment, if you laser the break. But if it's a partially detached, especially the upper one, you need to dry it because you may have the dryness post-operative with a fold or with a slippage of the retina.
Thank you.
I think we can move to the next talk. Dr. Ankur, can you please introduce the next speaker?
Yeah, it's a privilege to introduce Dr. Sharif Sharaway. He's a consultant vitreoretinal surgeon currently working at North Cumbria, UK. He's affiliated to Alexandria University, Egypt. He's a proficient surgeon and an avid researcher. He is a pioneer in the hypersonic vitrectomy, if I'm right. So over to you, Dr. Sharif.
Hello, hi, how are you? Thank you for inviting me, and I want to thank all the team in Pan Ophthalmologica and Dr. Vaibhav. It's a pleasure to be here. Can you hear me?
Yeah, you're loud and clear. You can start your presentation, please.
Yeah, sure. So let me open that. Yeah, can you see the presentation at the moment?
Not yet.
Let me share the screen. Apologies.
Yeah, it is now visible.
Great.
Yeah, you just have to, yeah, perfectly fine.
So today I'm going to be talking about retinal detachment proliferative vitreoretinopathy and how surgical strategies and lessons based on cases that I will show today. Sorry. So first of all, complex retinal detachment, either it's a PVR formation in which you get folds in the retina, you get complicated retinal detachment, which is usually longer standing, or a bit of other complicated cases like giant retinal tears. The primary failure risk for retinal detachment is PVR is 5 to 10% of the cases. And as you all know, the classification for the PVR, grade A, grade B, and grade C, with C causing foreshortening of the retina with folds up to closed funnel detachments. You can tailor your treatment on PVR on either minimal, which you can deal with as a normal retinal detachment, with maybe some peels or retinotomies if you need to, or moderate cases where you usually need something extra. We need to have adjuvant treatment, adjuvant instruments like PFCL, or you need to do something extra like retinectomy or reacting retinectomies. So first of all, visualization is the most important thing in VR surgery. So in order to visualize, we use Kenalog, we use trimethylone, or we use blue dye. So this is a patient that had a previous retinal detachment. You can see the tear with the previous laser, but there is an opening just beside the previous laser, but you can see I'm adding heavy liquid to try to attach the retina, and that doesn't flatten because of that star fold. You start to peel the star folds, which is the macula. There's no other way this retina will reattach. If you try to do a retinectomy, then it's useless because you have that membrane. As you can easily see how it's coming after staining and after taking that, the retina is back to place. As I said, there's a couple of options, which are scleral buckles, vitrectomies, or retinectomies when vitrectomies. So you can use a couple of those options. Is the retinectomy always needed? So this is a case of PVRB. You can see there's a macular hole, if you can see in the center. When the retina is wrinkled, you start removing the vitreous jelly. As Dr. Tawfiq said, you kind of understand how the retina moves, and as soon as you start to drain the fluid, if you think that retina will come back to place without needing any relaxing retinectomies or without cutting the retina. In this case, I've done an ILM peel. I usually don't prefer to do ILM peels on detached retina unless there's a macular hole for sure. On ILM peel, I've done a nasal flap, which is easier to take the disc as a hinge, so it's less mobile. Another option is to use PFCL. Also, but that's an option. And then as soon as I remove the vitreous jelly around the break, you can see the main break here temporally. Remove the vitreous around the break. You have to make sure that you shave this area very well, because that's the source of redetachment again. And then treating that tear after putting PFCL in, and you can see the retina has gone back to place nicely. So we know in that case, you don't need to do anything extra. No aggressive retinectomy is needed. And then direct, so PFCL air exchange, and then a gas bubble at the end to flatten the retina. Usually put these 3F8 in cases when you have a macular hole. Retinectomy and when and how. So again, we do a retinectomy when you find that the retina is unable to attach. You can try to test that if you're not very sure by either putting a fluid air exchange, which will show you the retina go back to place easily, or does it need something else, or is there anything else pushing it? So You need to decide that when there is shortening of the retina or there's contraction of the retina. So the technique is to perform dithermy thoroughly to prevent bleeding. Even if bleeding happens, that's not a problem. You can always remove the blood, but you tend to try to do dithermy as much as you can before doing that retinectomy. And PFCL is very important. It's the most important tool that we have when we're doing the retinectomy. So this is a patient that had an inferior retinal detachment with an inferior tear. And as you can see the shortening of the retina, or the wrinkling of the retina. That's the inferior tear. So getting the Schillern, and you can see long-standing fluid in that area, and taking that fluid out. So fluid to fluid exchange, and making sure that you start to shave around the area at the same time with removing the fluid, the subretinal fluid. I did my dithermy before I did my shaving, just to mark that area that I need to cut later on. And removing the vitreous and searching and for any other tears, and making sure that you can indent yourself and shave. And this is the retinectomy. You start by cutting the retina. This was a bit more posterior. Usually I go a bit more anteriorly, but yeah, you can see the bleed on the back of the eye from the area that we are cutting, and remove the anterior border of the retina, and that's very important. And you can see this retina starts to move nicely, and starts to be very easily to move, which that's the final thing that you want to see in order to put the retina back in place safely. And after heavy liquid exchange, after heavy liquid injection, you start to see how the retina flattens nicely, and then later on you apply your laser. I like to do some indented laser, especially to start with this horn, the peripheral horn. And my way to do a direct silicone oil PFCL exchange, I usually take the trocar out and inject the rest of the BSS complex with the rest of the PFCL that is left in the cannula, and inject a bit of silicone oil to make sure that there's no dead space in that area that would fill back into the eye. I use the 25 gauge, so I changed that to a 23 gauge in order to be faster. In this case, I have a chandelier, so I'll try to start to inject the silicone oil, and with my other hand I have back flush. The other hand I have another black flush because I'm using bimanual. So you can see the start of the PFCL bubble starts to pass the edge of the retinectomy, and this area you have to make sure that this edge is completely dry until the last piece of bubble. You can take it and you can make sure that you have a full oil. So this is a patient that had a vitrectomy with silicone oil injected, and this was the appearance in surgery with silicone oil, and the patient has a very large horseshoe tear and severe contraction. You can see how the retina is lifted with oil under the retina, which is a tricky case. You have to go in and remove and aspirate that area. I usually try to inject as soon as I remove the oil. And in this case, the only thing to do is a retinectomy. There's no other choices. And again, cutting all the edges of the anterior retina. And you can see this retina starts to move. That's a good sign. PFCL to unfold the retina and push the retina back to place. You can see how satisfying it looks when it's opening, like a flower opening, and then pushing the retina back in place. At that stage, sometimes, as you can see, there's an edge that is a bit lifted. You can always adjust that and do another dithermy and cut a bit more. That's not a problem, even after under heavy liquid. Again, after the laser, the same technique, and I do a direct oil exchange, which I feel in my hands is much safer rather than pushing into air with a risk of slipping. This is a case of scleral patient that a young patient with no PVD, and as you can see, he has a temporal detachment. Macula is on, but there is a subretinal band. A lot of people used to say when you have a subretinal band, it's better to remove those. But actually, in this case, I decided to go for a buckle. There's no PVD, so again, you can see the view from inside. You can see the subretinal bands. When you see those subretinal bands, they can always go to place. There's no need to panic about them. You don't need to remove them. Even during a vitrectomy, you can leave them. You can see the main tear here and searching for other tears and treating that main tear. It's a hole actually, not a tear. And you can see that hole with the cryo. Again, that's an area of hemorrhage. During that case, I have to make sure that I've treated all the suspicious areas, even including areas of hemorrhage. And I decided to put a local sponge in place because that was the only tear. There's no need to put a bigger or a wider buckle. So I've put that local sponge and do a paracentesis to make sure that I have a good indentation in the area. With the help of the assistants, push that local buckle into place to support that area of the retina and close the conjunctiva. You can see the retina is back to how it should be. And you can see the indentation of the local buckle and close the conjunctiva. That's the post-operative appearance. So as you can see on the left, that's the fluid and the subretinal bands. And on the right of the screen, you can see how the retina attached back to place. The macula was always on, so that's not a problem, but you can see that the subretinal band is there and without any problem. And this is the macular appearance. And that's the area of the band. You can see how the band is with the OCT, but we don't need to panic about that. My last case is a patient that had Leber's miliary aneurysm, had a previous retinal detachment. 2 years later, he came back with a redetachment. You can see there's a bit of vitreous left, and you can see how the vitreous is in the peripheral part of the retina, but that's not the main area not the main cause of the tear. But you can see we have to start shaving after injecting our dyes. Removing all the vitreous in the peripheral retina and making sure to remove all the vitreous around the areas of tears or holes. And this patient, as you can see, after staining, he had an area of wrinkling in the central area, and peeling that removed that membrane. Otherwise, it's very difficult to attach this retina without removing that membrane. And you can see how posterior that tear is. I'll show you later. It's a bit temporal. It's very posterior. So removing all the remnant vitreous or the PVR from the tear and doing a fluid air exchange, draining through the posterior tear. You can see how the exits are from the Leber's miliary aneurysm. I did laser on that area. In this case, because of the inflammation and because it's a recurring case, I've decided to put silicone oil instead. As soon as I put the oil, the patient had the oil removed later. Vision wasn't excellent, was 636, but expected from a case like that. So this is my conclusion for retinal detachment PVR. I've showed different options that you can try. You can try the options together. I usually don't like combined approaches where you put a buckle. I usually, vitrectomy is enough when I decide to go with vitrectomy, and buckle is enough when I decide to put a buckle in. We need continuous innovation, a lot of adjuvant materials that can probably help us with PVR cases and prevent the recurrence of PVR. Removing the membranes and removing most of the vitreous, I think, is the key of success in PVR. Thank you so much.
Thank you, Dr. Sharon. There were few excellent surgeries, quite amazing results.
Thank you.
I just have one few questions, one or the two questions. One is that, do you have any experience of using infusion of methotrexate or low molecular weight heparin with or with 5-fluorouracil, something which can prevent PVR?
I have heard about them. I've seen a lot of research publications about them, and a lot of people use them, but we are not still yet allowed to use them very much in retinal cases because they're not. I mean, it might be in studies, but not licensed to be used in the UK.
So, is there anything that you do if a patient comes to you with an extensive PVR and the retina settles down? How do you follow them up? Like, how often do you follow them up? The one that came with a redetachment, had a PVR with it, you reoperated that patient, retina settled now. How often do you follow them?
You mean after the surgery?
Yeah.
So I don't get skeptical. If I did the surgery and I did what I can, then I just treat them like any normal patient. I just follow up, probably, first day after surgery. I usually see them 1 week after surgery as well. Later on, I don't see them first day. I see them first week after surgery, 1 week after surgery. And then after that, I see them usually in 6 weeks if everything is fine, the retina is in place, he has oil, usually PVR, and pressure is fine, then I just see them 6 weeks afterwards.
And any kind of oil that you prefer, 1,000 centi-stroke or 5,000 centi-stroke, or it's just anything for you?
I prefer 1,000, centi-stroke, because it's easier to remove later on if you plan to remove it. But there are cases that that you're not going to plan to remove the oil very soon. So in those cases, I prefer to put 5,000.
Any other questions by our esteemed speakers? Dr. Alessandro? Thank you all. Thank you for joining us for this and for this evening session over here. Wonderful talks by all our esteemed speakers. And I think if there are any other questions by Dr. Kunal or Dr. Weber, are you there? Or Ribu?
No questions. Very interesting talk, Dr. Sharif.
Thank you. Thank you so much.
I think we can wrap up the session since talks are over. Thank you, everyone. And we have had very amazing learning this week, and we are taking a lot of tips from all our esteemed speakers and guests. So thank you, everyone, and we hope to see you again more in such meetings, and we would like to have you more towards in physical meetings as well.
Where we can interact more.
True.
Have a great evening. Have a great evening, everyone.
Thank you so much for everything. Thank you. Nice to meet you.